the day I found out I had a progressive like sensory event where basically my hand and foot, I woke up and it was just pins and needles. And because I was about to finish school, I could diagnose these things, and I had a really strong understanding of like the neuromusculoskeletal system. And so pins and needles is pretty much nerve, almost always. And so I was like, well, that's not great. But kind of ignored it, and it progressed to the entire left side of my body. And that's when I went to the hospital. They said they wanted to get an MRI, and as I'm being loaded into an MRI, for whatever reason, he's like, yeah, we're running a scan for MS. And, they shove me in the tube, and you're totally still, and you've got a cage over your face. And in my head, I started like doing the math, and I was like, this is not good. Like, I have MS. Like, I just knew at that moment. And, I don't think it really hit me the next day until I had to tell my mom. And my mom's a nurse. She's very well educated. And, having to like sit her down, I think she took it much harder than I did. And then I was just really angry. I was pissed. Through the McCourt Foundation, I think it's the understanding that that this organization is completely selfless. I think hope is really important for people, and there's the opportunity that like one day maybe I'm cured of this, you know what I mean? And I tell the story like this one time I had MS versus I have MS and will always have MS.
I'm a neurologist at the Massachusetts General Hospital, and I specialize in multiple sclerosis. And I've been at MGH now for just a little over 10 years. So my research focuses on a couple different areas. One is related to clinical trials. So looking at new therapeutics in multiple sclerosis. I also have a research lab that is devoted to imaging, so looking at new ways to assess multiple sclerosis, ultimately to come up with biomarkers that we can use in those clinical trials. I saw that there were some big opportunities to improve our treatment of the disease. And MS is also unique in the sense that most people are diagnosed at a relatively young age, in their 20s or 30s, a time when they're really in the productive years of their life. And I felt like this was really a condition that, as a physician, I felt like I could really make an impact on people's lives. Partnering with the McCourt Foundation now for, I think, more than 5 years. And I think it's been really valuable to making an impact on our ability to treat people with neurologic disease. And so myself as an MS specialist, I can tell you that really some of the most valuable partnerships allow us flexibility in really focusing research funds where they're needed most. And so I think that there's a big advantage of being able to say, here is an immediate need or an immediate question that needs to be answered, and to be able to do that as quickly as possible. So that's just one example of how this partnership with the McCourt Foundation has been just really valuable and allowed us to make impacts immediately.
My dad, I'm an only child. I grew up in the house that my dad grew up in. And he's just, I know I'm biased, but he's one of those really special people who touch a lot of lives. And I've really realized that since, he was a police officer in the town that I grew up in. He would just, throw off his gun belt, play basketball with kids. He just was an inspiration and still is. And his positive outlook on life, I try to kind of channel when I'm having a tough day. So always went the extra mile to help people. He's inspiring to me because he was always so positive and had the strongest kind of mental ability of anyone. Like, he could push himself through anything. And he inspired me as a child in many things, but running was one of them. He got me into it. He ran a bunch of Boston marathons, and I grew up on the route, so I got to watch him. Looking back, there were probably some signs, but he got it. He was diagnosed with early onset dementia. They called it semantic dementia, so it's a loss of words initially, and then it kind of flows more into Alzheimer's. He started to kind of describe around things, and that's when we kind of, he wouldn't be able to think of a word like sweater or something like that, and he'd say, the thing you wear to keep you warm. Receiving the diagnosis, though, was really hard. They first diagnosed it as depression, and we were like, he's the least depressed person we know, but I think it was probably in his head, it was tough because he didn't know what was happening to him. Again, I always wanted to run the marathon with my dad, but that didn't happen, and I was fortunate enough to find McCourt Foundation, who had a team, invited me on. I raised more money than I ever thought I could raise. I raised $19,000 that year, and the way their family is so invested in helping, and it was amazing. And I look back and I think, even though the weather was terrible the year I ran, it was one of the best experiences of my life, and one of those big bucket list goals that I always had, and I knew my dad would be so proud. He definitely helped me get through those latter miles of heartbreak and hometown stuff.
The Department of Neurology is part of Cedars-Sinai Medical Center, and we think of ourselves as neurosciences, so that includes both our neurosurgical partners as well as our neurologists. We work together. So we have world-class neuroscientists who are using an opportunity that we get from epilepsy surgery to really understand fundamental ways that the brain works, and in particular forms memories. And as you know, this is a key area for dementias, for Alzheimer's disease. And so we're doing work with patients who are undergoing depth electrode placement for possible surgical resection. And so they're having recordings done. And while they're sitting on the ward waiting to have seizures that are informative and help with their surgical planning, they're also doing experiments, and they're having recordings done. Fundraising is so important. I think about it as like the rocket fuel that gets things going. It allows you to do things that are maybe a little bit riskier, but also have the biggest payoff. So when we're trying to really do unique, kind of new and risky things, having philanthropy allows us to really do that crazy experiment, take that risk. So in those early years, it's really critical that we have access to funds so that we can really support these really exciting people. And so if we can really raise the level of care that people are receiving and raise access throughout the Los Angeles area, it's really the goal of Cedars as a medical center, and make all of the cutting edge therapies that we're working on available to the widest number of people across Los Angeles. So that's the thing that gets me really excited when I'm thinking about what we're working toward, because we have this opportunity to really sort of raise the standard of care, not just for the people who are here at our medical center, but throughout the whole Los Angeles area.
I'm Meritz-Kovich. I participated in the Georgia South Shore many times on Team MGH. We've raised money to support research that TMF supports. I've never run it or biked it. I've just walked it, but it's a great event. What I love about TMF is they support several disorders, several brain disorders that have overlapping biology. And by doing that, they bring teams together to solve these diseases that affect so many people. So I'm Chief of Neurology at Mass General Hospital, and I also run our ALS or Lou Gehrig's center. So in my chief hat, it's really about promoting young investigators and taking great care of patients and really trying to solve some of these diseases. With my ALS hat, it's really about how do we innovate and get treatments developed for people with that disorder as fast as possible. ALS stands for amyotrophic lateral sclerosis. It's a really awful illness. It's one of the worst ones out there, where people in their mid-50s often will start to lose ability to use their hands or to walk or to breathe and talk. It's a fatal illness. And really, we don't have a lot of good treatment options right now, but there's a lot of research, and we need those funds to kind of push those great ideas from the lab to patients to trial. Our clinic is all about hope. It's about what can we do for you today, and what are the options, and making sure people have options for trials, for compassionate use, that they know everything that's going on, because there really is a lot of hope out there, and it's important for patients to go to doctors and teams that know what's going on and can give them options. In ALS, I think huge hopes of a cure, I hope, if I can say that word, for the genetic forms really quickly, really soon. The technology to block gene mutations in the brain and people is there. There's already trials going on, and if we can stop the cause of it, I think there's huge hope we can really stop the illness. For the other 90% of people who don't have the genetic cause, I still have a lot of hope, but it might be just a little farther away.
Good morning, everyone. I'm Brian McCourt, president of the McCourt Foundation, and we'd like to welcome you all here today for the first ever virtual McCourt Foundation educational update. We've got a fantastic lineup of physicians that will be presenting today. Physicians that are not only top in the country, but top in the world in their respective disciplines. We're excited about having you all here and hosting you, and would also like to thank all of our sponsors that are making this possible. But I'd like to especially thank our presenting sponsors, Bristol Myers Squibb and UBS Financial, as well as our silver sponsor, Sanofi Genzyme. But I would like to thank all of you for being a part of this day. This has always been one of our favorite and most impactful programs, and it's all because of you. So enjoy the program. I'd like to now introduce Steven Sypek with UBS Financial.
Thank you, Brian, and thank you for joining us today, and welcome to the McCourt Foundation Educational Symposium. My name is Steve Sypek, a financial advisor with UBS Financial Services here in Rockland, Massachusetts. I've been friends with the McCourt family for many years and personally involved with the foundation for over 20 years. I too have been impacted by neurological disease, and that my mother passed away from Parkinson's 5 years ago this year. I am excited for today that you will be hearing from the top doctors and researchers from Massachusetts General Hospital, Brigham and Women's Hospital, and Cedars-Sinai Medical Center on their progress and developments in the areas of multiple sclerosis, Alzheimer's, and ALS research. We all know the challenge that individuals and their families face in dealing with neurological diseases. And that is why I believe the McCourt Foundation focus on making things better by supporting research, providing education, and developing strategic health-focused partnerships will one day lead to a cure for many of these diseases. As a financial advisor, I know the challenges that these patients and their families face in planning for the unexpected and in dealing with the emotional, physical, and financial challenges. We believe that the financial services industry can help families plan for those unexpected circumstances, and also help support the critical research and awareness in the areas of neurological diseases. And that is why UBS is excited and proud to support the McCourt Foundation in their great work and their mission by sponsoring today's educational update. Thank you for joining us. I hope you find these sessions helpful, and that they will continue to inspire and empower you and your loved ones in making things better each and every day. Enjoy the upcoming update.
Good morning. This is Dennis Selko, reaching you from Boston, and I'm delighted to be here with my colleague Mark Albers. We are both neurologists working on the forefront of dementia and Alzheimer's disease and related disorders. And this morning, through the McCourt Foundation, we have the pleasure of telling you about a little bit about the disease, answering your questions, and about our work on the disease. So with that, I'm going to share my screen. Let's see if I can find it. Here it is. All right. I'm hoping that you're able to see this now. And what I thought I would do, and Mark will do this similarly a little in just a few minutes, is to give you my sense of some of the issues we face in dealing with this tragic disorder of Alzheimer's disease, which is so very common. And we'll share with you some of the knowledge that the field has acquired and some of the things we still don't understand, and a little bit, most importantly, about what I'm sure all of you care about, which is the therapeutic approaches to this disease. And both Mark and I will speak to that. Uh, so let's talk a little bit about where we stand and where we need to go. Alzheimer's disease in 2021 is the most common cause of dementia, and I'll define some of my terms in a moment. It affects well over 5 million Americans, probably 40 to 50 million worldwide. We don't know the exact number. And that number probably is an underestimate because the field has redefined Alzheimer's in the last decade or so as the disorder that causes abnormalities in the brain, and gradually those abnormalities build up even prior to the first symptoms, the first time you forget where you parked your car or forget the name of your 10th grandchild, if you're so blessed. Those early symptoms are preceded by a long period of abnormality in the brain. So in some sense, there are any number of millions of people incubating the disorder who aren't aware yet that they have symptoms. And this is true for many chronic disorders like hardening of the arteries, atherosclerosis. It's there for a long time before you have your first twinge of angina. So Alzheimer's occurs in all races and ethnic groups across the globe. It's relatively similar in its prevalence. And people in America of African, European, Asian backgrounds will all experience Alzheimer's, and it'll be a prevalent disease in their society. We see it in China, in India, Japan, all over Europe. And so it's a universal foe of good health. It's expensive, and here I quote a figure of about $250 billion in annual cost. We, again, don't know the precise number. It's probably north of that. And it recently was estimated in the New England Journal of Medicine that the cost for all aspects of Alzheimer's, principally for caring for patients during the long time that they suffer the symptoms and the neurodegeneration of the disease, that total cost for our society may be more than the combined cost of all of hardening of the arteries, that is atherosclerotic disease, and all of cancer combined. So all of cerebrovascular and cardiovascular disease plus cancer, the cost of Alzheimer's for our society is still greater. And yet the amount we spend on research is not in proportion to that. And I'll mention that there's no cure for disease-slowing treatment at present, but both Mark and I will speak to how we're hoping that's going to change, perhaps even relatively soon. It's an exciting year where we're going to talk more about therapeutic opportunities. So to share with you some of the current concepts, senile dementia is a term we use in medicine. Senility is a lay term, and we think of it as progressive mental failure after age 65. So this is the general formal definition. We know there's no strict cutoff, and there are so-called pre-senile forms before age 65, and that's really a continuum. So it's not like two groups of people. The disease can occur rarely in even the 30s and 40s, that's very unusual, and then in the 50s and 60s, and increasingly more prevalent as people get older. Alzheimer's is the most common of maybe 20 causes of this concept of dementia or loss of mental ability that comes with age. And it may account for 60 or 70% of dementia cases in the US. But I should say that many of those 2/3 of dementia cases that have Alzheimer's don't just have Alzheimer's. They may have other changes in the brain. Commonly, they may have minor or major vascular abnormalities, microvascular disease. And that, of course, makes it harder for us to devise treatments for Alzheimer's because the disease is not entirely pure. It's more pure in people who have hereditary forms that begin in midlife. As you read here, Alzheimer's begins insidiously, usually with decreased memory, confusion, disorientation, maybe some word-finding difficulty, and it progresses slowly over 5 to 20 years. It is fatal. People are sometimes surprised at that, but many neurological diseases are ultimately fatal. They don't directly stop the heart from beating or the lungs from expanding, but they cause so much debility, so much difficulty that patients have a variety of secondary and tertiary complications. And many of my patients with Alzheimer's will pass away at the night when, even as good as their care may be, there's a time for sleep for both them and the caregivers, and they will have a little bit of aspiration or some phlegm getting stuck in their throat, and that final respiratory event is what will take their lives. But the reason they died, of course, was because of this progressive Alzheimer's. Here you see a list of other types of late life dementia, and Alzheimer's disease is at the top of the list because it is the most common we see. It used to be that vascular dementia, or what has been called multi-infarct dementia, multiple small or medium-sized strokes, could be considered the most common cause of dementia. But with the 50% improvement in atherosclerotic disease and hardening of the arteries in our society, there's less of that now. And we've controlled blood pressure, to some extent diabetes and cholesterol levels pretty effectively. So we see somewhat less of that, but it still happens. And some of it happens in a way that the patient and the doctor can't tell. Parkinson's disease with dementia is also common. Parkinson's in general is about a third or a quarter as common as Alzheimer's as a disorder. And most people with Parkinson's eventually will develop dementia. A special form of dementia we refer to as dementia with Lewy bodies, and that's related in part to Parkinson's disease with dementia. But when the Parkinson's changes and the dementia begin essentially at the same time, then we think of dementia with Lewy bodies. Whereas in Parkinson's disease, you begin with the features you may know, with trouble getting out of a chair, walking, tremor. They come first, and the dementia comes years later. But dementia with Lewy bodies, both dementia and a Parkinson-like picture, arise simultaneously, and it's a very difficult disease. Frontotemporal dementias are another large category, including Pick's disease and other diseases that have unusual names. And these are sometimes due to the protein tau that I'll mention. And then Creutzfeldt-Jakob disease and other diseases that are so-called prion disorders are very rare in society. One renowned and notorious example was what's called mad cow disease that occurred in Britain 20 years ago or so, and can still happen, but that was a very unusual situation where an unusual form of infectious particle called a prion was in the brain. That has really very little to do with the other disorders. And so Alzheimer's disease is at the top of the list. But we think about this differential diagnosis when we see patients in the clinic. Our job is to figure out what form of dementia, and there are others not listed here that could be causing the patient's symptoms. I want to mention here, and this will be relevant to Mark's work and his presentation, that we generally separate treatments for any disease as symptomatic treatments versus disease-modifying treatments. So for Alzheimer's, the symptomatic treatment are the so-called acetylcholinesterase inhibitors, and they have names like donepezil and razodine and galantamine, and these are drugs that have been on the market for 20 years. The most well-known brand name is probably Aricept, but there are others, Exelon, razodine. And so these are agents that help the symptoms for a little while. They help the loss of acetylcholine in the brain, but they don't really slow down the course of the disease. And that's been looked at carefully, and there's very little evidence that they slow down the course. They may be helpful for a few months or a year, or sometimes a little longer, but they're symptomatic. They're not disease modifying. What everybody cares about is disease modifying treatments, and we'll talk about those a little bit more. To get to disease modifying treatments where you actually, for example, an example of these two classes of drugs would be someone who comes forward with a sinus headache, and I tell them, well, you have a bad sinus infection. Here's some Tylenol. You're going to feel better tonight. And they look at me puzzled and say, doctor, I didn't need to come to see you to get Tylenol. And then I'll say, well, of course, we need to give you a prescription for penicillin. And in Alzheimer's, we just say the first, but we don't have the second. We don't have the treatment yet to offer that really slows the disease. So to get to disease-modifying treatments, we have to really decipher the disease. And here you see a picture of a part of the brain that is important for emotional control called the amygdala, and behavioral symptoms can arise in our patients when this area is affected. Also, the area called the hippocampus and then the cerebral cortex will have the abnormalities you see here. So in this image, which is a section of the brain, the area that, for example, is in the upper left or the lower right of this slide is how a normal brain might look. There would be no large round lesions like you see here, and none of these very dark brown nerve cells or neurons. So the lower right area would be the normal situation, but this patient has, in this high power view, 2 amyloid plaques. So the amyloid is the central material, and it's made up of a protein called A beta. And the title of my slide mentions amyloid plaques made of A beta. And the plaque is surrounded by or permeated with abnormal axons and dendrites. These are the nerve processes that connect one nerve cell to another. Sometimes they're very dilated, like you see here. And so if you are medically connected and you're attending this talk, these are so-called neuritic plaques. They have abnormal axons and dendrites or neurite. Adjacent to the 2 plaques in this patient's brain are tangles. These are so-called neurofibrillary tangles made up of a protein called tau. And the cells with this particular stain of the brain should look sort of like this, and not with this dark brown material that's sort of stuffing the neuron. This happens to be a brain section taken from a patient who I followed during life, and he died at age 69. And his mother had Alzheimer's before him. And we didn't know it at the time, but probably he may have carried the so-called ApoE4 allele that we'll talk about in a moment. So these are the plaques and the tangles. The plaques are the round spherical lesions, and the tangles are inside the neurons that are the hallmark of the disease. And that for decades, people like Mark and I and people before us have been trying to decipher to understand, are they the cause of the disease, so to speak, and can we interrupt them? Now, I'm going to give you an example in this cartoon I'm going to show you of how we think about the amyloid part, that is the plaque part of the disease. We think about the amyloid protein in these plaques arising from a cutting process. Here is a cell, a cartoon cell with a yellow cell wall. It could be a neuron. Actually, this could happen in muscle cells and skin cells and elsewhere, but in the brain, we care about neurons. And in this neuron, there is a protein in this simple cartoon in red and black that's called the amyloid parent protein, or APP. And I'm going to show you that the generation of this amyloid beta protein, which is the black box here, this occurs normally throughout life in all humans. But if it happens in a certain bad way, it can lead to the aggregation of that peptide with age in all primates. And so we've studied this, and actually cats and dogs at home, when they get beyond about 15 or 16 years of age, they may have these same amyloid deposits. So what happens in this neuron that has an amyloid parent protein is that there's an orderly cutting process by an enzyme called beta secretase, or BASE, and that releases part of this, and it leaves the rest of the protein still in the membrane or the cell wall. And then there's a second curious cut by an enzyme we call gamma secretase. Secretase means it secretes something, and that cuts in the membrane wall, and it releases the amyloid beta protein. So what I've just shown you is what all of you are doing as we speak, and so am I. This happens normally throughout life, and everybody makes A beta. So do lower mammals, even animals that don't seem to get Alzheimer's. But when A beta teams up with another A beta molecule, 2 of them together form a dimer, one alone we call a monomer. They can even form trimers and tetramers and larger assemblies. And collectively, those teaming up of the A beta into assemblies, we refer to in science with the word oligomers, a few units or a few mers. So oligomers, we have come to believe through work in many labs, including Mark's work and my work and many others, are a type of smoking gun in Alzheimer's. They are noxious, and they short circuit synapses. And those oligomers can make filaments or protofibrils and then fibrils, and those fibrils make up the amyloid plaques. So here I'm coming back to the image I showed you before. I've showed you how a normal protein called amyloid parent protein, or APP, can be cut by two enzymes, beta and gamma secretase, to release A beta. And then the A beta, if it stays as a monomer, is okay. But if it teams up with another monomer and makes a dimer, and then there are dimers of dimers, doublets and quadruplets, that's not good. And that, we think, can short circuit nerve cell function and lead ultimately to the other major lesion, the tangles of Alzheimer's, made up of the protein called tau. So A beta in the plaques, tau in the tangles, are something we desperately want to avoid allowing patients to accumulate. One idea about Alzheimer's, a hypothesis that's not yet proven, but there's more and more evidence for it, is that you could think of Alzheimer's as a syndrome that is not just one disease, but a disease with many causative factors that's caused by an imbalance between the production and the removal of this amyloid beta protein, the little black box in my last diagram, that leads to its gradual buildup in brain regions serving memory. And we believe that this imbalance can be caused by different genetic factors and or environmental factors. We don't know that much about exactly how environment leads to Alzheimer's per se, but there's some ideas about it. And one of them may be the experiencing head trauma can maybe trigger some of the lesions of Alzheimer's and even some Alzheimer-like symptoms. So this theory is called the amyloid hypothesis, and many people around the world have been working on it. And the drugs that are coming forward now are mostly directed to doing something about the problem that you see here that's outlined in this hypothesis. So the best evidence for this possibly being the mechanism behind Alzheimer's, and therefore worthy of drugs that could modify it, comes from familial Alzheimer's. For a long time, we've known that, like many other chronic diseases, Alzheimer's can run in families. And so the question is, how do defects in certain genes lead to Alzheimer's disease? And there's been a lot of progress in the last 20 years to understand genetic factors. And through the power of human genetics, scientists have discovered genes that lead to Alzheimer's. I'm going to show you an image here of many, many plaques in the gray matter, or the sort of the thinking part of the brain, the cortex of someone. And these many brown deposits are kinds of plaques. We call them earlier diffuse plaques or preamyloid plaques. And you see in the lower part of the screen, things are clear and white. That's the white matter of the brain. But in the upper part, most of the screen shows the gray matter of the brain, the cortex, and also the hippocampus, which is not shown here, accumulates many of these. And what's really shocking is for me to tell you this happened in a 12-year-old boy who died at Children's Hospital in Boston. And the question is, what would cause a 12-year-old boy to have these very much Alzheimer-like plaques of A beta or amyloid beta protein at age 12? And the answer is that this image comes from a 12-year-old boy with Down syndrome. And many of you have heard of Down syndrome and are familiar with it, also called trisomy 21, because there are 3 copies of chromosome number 21. It turns out that people with Down syndrome invariably develop this abnormality in the brain of Alzheimer plaques. And indeed, they get tangles as well a little bit after the plaques accumulate. And they eventually can lose ground. We know that Down syndrome patients have varying degrees of intellectual ability, and they have compromise of that, many of them, but they can do a lot. They can go to shelter workshops and they can go to school. However, when they get into their 20s, 30s, and beyond, they may lose ground. And that's because they seem to have acquired a secondary Alzheimer problem. Well, why is that? The reason is at the top of this list here. Chromosome number 21 is where the APP, or amyloid parent protein gene is, the gene that encodes the amyloid parent protein. And so Down syndrome patients have an extra copy of chromosome 21, and invariably they'll develop lots of amyloid plaques, A beta deposits, already in their teenage years. And so when this was known, scientists began looking carefully at the APP gene in many families with Alzheimer's and found some families that had mutations in APP. And in my lab and a couple of other labs, we studied that, and we said that the effect on beta amyloid, the beta amyloid phenotype in the brain, is to increase the production of A beta peptides, and especially A beta with 42 amino acids, A beta 42. Now, not just a year after these mutations were discovered, a gene variant called ApoE4 was linked to Alzheimer's quite dramatically. And it turns out that in this case, it's not increased production of A beta, but increased density of A beta plaques. That is, it seems to be mostly clearance of A beta that's faulty when you have a gene called ApoE4. And there are three variants of ApoE, E2, E3, and E4. Interestingly, E2 is protective against Alzheimer's, or at least amyloid deposition, and E4 is bad for it. About 20% of us in society will carry an ApoE4 gene that we got from mom or dad, either one. And that'll increase the density of A beta as we age. And then there's two quite rare genetic abnormalities, presenilin 1 and presenilin 2. The name sort of implies presenile Alzheimer's, and they get Alzheimer's disease in their 30s, 40s, and 50s. And those two similar genes, when they're mutant, can increase the production of this A beta 42 peptide, or its levels. So this is the familial form of Alzheimer's disease. And in each case, when we found a genetic abnormality, you'll see an abnormality of A beta. And so that's support for the idea that A beta can drive it, because we have no doubt that these genes can trigger or cause the disease. So that comes to the end of what I'm going to share with you in just a couple of more slides, to remind you of this distinction between symptomatic treatments like donepezil, Aricept, and others, versus disease-modifying treatments, which we're working hard to try to get. We want to interfere with what you just heard about. We want to stop this buildup of A beta into oligomers and then to filaments and fibrils and plaques, and what we think is a secondary tau alteration that's very important. We think only when the patient develops tau tangles in nerve cells are they likely to begin to show serious memory symptoms. And so the drug that's furthest along, the treatment that's furthest along in trying to do something about what I've told you in this talk, is referred to by the name aducanumab. MAB at the end means monoclonal antibody, and aducanumab is a made-up name for a particular antibody developed by a company, Biogen, which happens to be headquartered here in Cambridge, Massachusetts. They did a trial, a phase 1 trial called the PRIME trial, and in that trial, they showed that over 1 year, they could lower the amount of amyloid, which is shown strikingly with an amyloid PET scan, a tremendous breakthrough that was made at the University of Pittsburgh to find compounds that you could inject into the vein, cross the blood-brain barrier, and they would light up the amyloid plaques. And the pseudo-colored image, red and yellow, is what you don't want to have. These are excess amyloid plaques. Placebo for 1 year doesn't do much about this picture. These are actual images of patients in the trial. But giving 3 milligrams per kilogram body weight per month of this antibody, and you give it intravenously, begins to decrease the amount of A beta. And there's a dose-dependent increase, 6 and 10 milligrams, in this early small trial of 165 patients. So this isn't enough to get a drug approved, and Biogen went on to do large trials in 20 countries. Here's an example in a graph of one of their trials called eMERGE, and shows the longitudinal change from the baseline at the beginning of each patient's entry into the trial of their amyloid PET signal. So this amyloid PET scan, which is what I showed you here, the red and yellow signal is what we don't want to see. The decrease is striking and is dose dependent in this trial. And this was one of 2 trials. The other trial also showed lowering of amyloid in the brain over 78 weeks, although the other trial wasn't quite as strong, had a little bit less amyloid lowering. And then finally, what's the story on that? Does it matter to the patient? And the jury is sort of mixed in this trial. In purple is the degree of decline in a particular test. Activities of daily living, a very important test that tells how people function in everyday life. The degree of decline is less here with the highest dose of aducanumab each month than it is with the placebo infusion given each month. And that difference is significant, but it's not a very small difference, and the patients still decline. So what Mark and I and many colleagues in the field are trying to come to grips with is whether these data, which were impressive in this trial, but not near as impressive in the other trial, subsets of patients in the other trial showed some benefit, whether that will lead to an approval of this drug by the FDA. And that decision will come in June. So to summarize what I've told you, it turns out that Alzheimer's is a complex process that unfolds over years. And many of us believe that buildup of amyloid beta, followed by buildup of the tau protein, leads to the plaques and the tangles that Alzheimer originally described. We want to interfere with that. That is, we want to modify the disease. And we're hoping that drugs like aducanumab, which has not yet been decided upon by the FDA, will take us in that direction. There are a number of others that are very exciting that seem to do similar things. So with that, I'm going to stop and unshare my screen and ask if, let's see if I can unshare, stop share. Good, and I'll return to Mark, and maybe he'd like to take it from here. And then we're going to, of course, go into questions and answers after that.
Thank you, Dennis. That was wonderful. And thank you so much for that great introduction. I'm very excited to join and be able to share some information and thoughts related to Alzheimer's, and in particular, what we've been working on is asking if we can repurpose drugs that are already FDA approved to help with memory loss in Alzheimer's disease. And so I want to start by just redefining what is drug repurposing. And that is taking FDA approved drugs that are already on the market and asking, would they have any activity for different diseases than the ones that they were approved for? And so just to give you an example, there's been lots of work in drug repurposing for the COVID pandemic. And there's a drug called baricitinib that has it's an anti-inflammatory drug that's been approved for rheumatoid arthritis, but it's also now achieved emergency use authorization for COVID disease, and in particular to prevent patients that have COVID to progress to the severe form of disease where they have pneumonia, need intensive care unit, or and ultimately could pass away. And so this is an example where people were looking for ideas of drugs that already existed and maybe can help with a different disease type. And so I think because we're talking about diseases on the market, I just want to be very clear about two things. One is that I don't have any equity in any of the drugs that I'm going to be talking about, or in the companies that make the drugs that I am talking about. But also, just very importantly, what we're talking about here is research. And the drugs that I'm going to mention are, again, need further research. So this is what's called off-label use. And if we nominate a drug, that means it needs to go into a clinical trial for testing. It's not something that one should use to go to their doctor today and say, I heard this talk, could I go on this drug for Alzheimer's? This is still very much research, and I just want to make that very clear. And so this is a paper that just came out last week, so very excited to be able to tell you about it. We used a technique called machine learning, and I'll define what that is, to look in a more unbiased way at all the different drugs. We looked at a subset of drugs in a number of cases with Alzheimer's disease. And we kind of let the computer teach us what might be a signal that's worth following. And so what we started with was, as Dennis so nicely and beautifully laid out, is a set of brains from different places across the country. So in Chicago, in Jacksonville, Florida, and in New York. And these are brains that have come from autopsy samples. And the progression of the Alzheimer's pathology through the brains varies amongst these different brains. But you see the numbers here on the right. So we're looking at over 1,500 brains, and they will have different levels of progression. And then different parts of the brain were selected out, and then all the genes that were expressed in those regions of the brain were categorized. So now we have this enormous data set of 1,500 brains, 20,000 genes, and so it's too much data for a human to look at and try to decide is there a signal there or not. So that's why we decided to use computer approaches, and in particular machine learning. So what is machine learning? It's a term you probably hear a lot about, and it's something that I'm still learning about. But essentially what machine learning is it's taking a huge data set like that and asking the computer then to learn based on how we define it, and I'll tell you how we categorized it, to look for differences. And then in the second part, it builds a predictor. So that based on the data that you trained it on, so you taught it, then it builds a predictor, and now you can feed in new information into the predictor, and then you get an outcome, a prediction coming out, and then you have to test that. And in Alzheimer's, what that means is we need to test it back in the laboratory, so either cell models, animal models, or ultimately to clinical trials. And because what we're talking about are FDA-approved drugs, then we have the opportunity then to move to clinical trials more quickly than drugs that come out that have not been in humans. We don't understand their safety program. So here's a complicated slide, but the heart of it is in the third, number 3. I'm not sure if you can see my pointer or not. I don't believe so, but I'll just talk you through it. So in the middle of the slide in 3, we took these brains and classified them into early stage disease, which is where people mostly don't have symptoms, medium stage disease, where they would have symptoms, and late stage disease, which would correlate more with moderate or severe forms of dementia. And then we asked the computer to tell us what's the difference between the early stage disease and middle stage disease. What's the difference between middle stage disease and late stage disease? How are the genes changing in these different regions of the brain? And from that, we built the predictor. And again, this is work of Artem Sokolov and Clemens Hug. And then that allowed us then to take other gene sets and feed it into the predictor and ask, would these particular genes be important for progression of Alzheimer's disease? And so we confirmed our predictor. We took known genes that are involved in cognitive decline, and that was the predictor worked well. It had a very significant signal. And so then we felt more confidence in our predictor. And so then we moved forward to ask about drugs, and FDA-approved drugs in particular. And so what we did is we took cells that grow in dishes in the lab. They're human neural cells, so they're brain cells. And then we treated those with drugs, these FDA-approved drugs, for a short period of time. And we looked at what genes changed in response to those drugs. And then we would take those genes that changed and feed it into the predictor and ask, if the drug would move genes in this direction, would it be helpful or not? Would it have a signal at all in terms of the genes that are changing with Alzheimer's? And these are the top hits that emerged. So on the left are drugs that are FDA approved. And on the right are drugs that are either have been in humans in clinical trials, or they're investigational drugs that are just getting into humans. So let's focus on the left-hand side. These are drugs that are already FDA approved. And we see a number of different drugs. On the left, is the blue line. It's the approval. They've all been FDA approved. The first thing we did was ask, do any of these drugs cause toxicity? Because if they cause toxicity on the cells, well, that might be something that would be positive in our predictor, because neuronal death is part of Alzheimer's disease. And so one of the drugs dropped out. That you can see the red there. That one caused toxicity, so that one's off our list. But what emerged from this, which was quite exciting, is a class of drugs. The number one hit was ruxolitinib. But if you look down the list, there are a number of drugs that hit a protein called JAK, J-A-K. And JAK is a protein that's involved in inflammatory signaling in the body. And these drugs are approved for either rheumatoid arthritis or hematologic malignancies, so non-brain diseases. But including on the list is baricitinib, the one that I mentioned earlier, for that's been FDA had the EUA authorization for COVID. And so because of this class effect, we were particularly interested in that. And then secondly, and I won't have time to go into it, we've been working independently on a mechanistic study, and we've been seeing increased signaling, antiviral type signaling of immune cells in the brains of patients with Alzheimer's disease. And so this is just an example of this. This is a particular antiviral signal. This is antiviral signaling, an immune type of signaling that's in response to viruses. And we see that these are different genes that are increased in different regions of the brain that are relevant for symptoms in Alzheimer's disease. And in fact, this particular inflammatory pathway is blocked by those JAK inhibitors. And so we have then the computer led us down this road to this class of drugs. And then independently, we've had a mechanistic approach that has led to inflammatory signaling being present in patients with Alzheimer's disease. And in fact, to be more specific, what we see it is in about half the patients with Alzheimer's disease that we've been able to study in autopsy brains. And we have markers for this path, for this particular inflammatory signaling in the spinal fluid of living patients. And so we want to study whether if we would change those inflammatory markers, would that have a positive effect on Alzheimer's disease? And I know later today you're going to be hearing about the cutting edge works from ALS, from Dr. Sudakovic, Dr. Gozala, it turns out we see the same inflammatory signaling in ALS as well as Alzheimer's disease. And so the clinical trial that we're about ready to launch in, we think, late spring or early summer, is what's called a basket trial, where we're going to take patients with Alzheimer's disease and ALS and look for their inflammatory markers in their spinal fluid. If we do see them in the spinal fluid, then they come into the trial and they'll be treated with one of these JAK inhibitors, baricitinib, for 24 weeks. So it's an open, everybody's going to get the drug in this clinical trial. And what we're really asking is does the inflammation in the blood, and also in the spinal fluid, is it reduced in the presence of this drug in particular? And we'll be also looking in the spinal fluid at markers of what Dennis was talking about, A beta levels, tau levels, and neuronal death markers as well. And so we're very excited about this. The trial is entirely philanthropically funded at the moment. We're also applying for grant support, but it's a wonderful expression of different foundations and grateful patients, et cetera, that have enabled us to take this drug candidate where we have convergent evidence and then move it into a clinical trial in a very short period of time. And so I just want to thank the team that I'm here to represent, a wonderful team. There's you can see that both here at Mass General, at Harvard, and then in London, And then particularly Artin Sokoloff, again, Clemens Hug did the computational work, the machine learning work that I talked about, and Steve Rodriguez did the work that was related to the in the culture models and things like that. So with that, I'm happy to turn it over and open it up to questions and look forward to all of your responses. Thank you for your attention and thank you for being here on a Saturday.
Great. Thank you very much, Mark. Right, and you can unshare and then they'll be able to see us. And I think the most important part of this after the presentations that Mark and I made in the search for therapy is to answer your questions. And we're prepared to do that. So I don't know how the questions are coming to us. Are they going to be articulated or coming by chat? Nothing in the chat room so far.
The questions are in order as previously discussed.
Okay,
Well,
good.
the
So
first
you want
question
us?
Are dementia and Alzheimer's two separate conditions, or is one a precursor to the other?
So Mark, please go forward.
Yeah, so I think that when we Dennis did a beautiful job of laying that out. So just to very briefly summarize what Dennis had already said, and he's really a leader in this field, so you can't hear it from a better person. That dementia is a more broad term that talks about cognitive dysfunction leading to trouble with your ability to perform in everyday. And the most common cause of dementia is Alzheimer's disease by far. And so it's now patients can have changes in the brain for many years, as Dennis was saying, that are defined as Alzheimer's disease pathology. And those patients, many of them, and most of them will, if allowed to live long enough, will develop the disease of dementia. And so you can have Alzheimer's changes in the brain of patients that are not having any cognitive symptoms. And so we would talk about those patients as having Alzheimer's disease pathology. But in terms of dementia, when people actually do have cognitive symptoms, the most common cause of that are changes that are due to Alzheimer's pathology. And Dennis, if you would want to say anything.
I think that says it all. I think for all of the patients and the caregivers who are listening in, this is what each family needs to deal with. What is the cause of my mother, my father, and my brother or sister not thinking as clearly? And specialists, neurologists, geriatric medicine specialists, psychiatrists are trained to figure out, is this dementia, number one? And if it is a dementia, what is the cause of the dementia? What is the form? And that's what we do in the clinic. So I think hopefully many of you who are dealing with the reality of Alzheimer's have gone past that point and have had a diagnosis by a specialist. So I think we can go to the next question.
Question 2 is this disease inherited, and how many generations does it affect?
So I'll take that one. And as I mentioned during my presentation, and these questions actually were formulated before we had a chance to share our respective presentations. So indeed, we dealt with the notion of familial Alzheimer's. So this has been known for decades, probably centuries actually, to run in families. And yet there are any number of patients who come to see us in the clinic who don't have an obvious family history. So one doesn't have to have a family history. One doesn't have to have a clear-cut genetic pattern. But what I always quip is that one needs to choose one's parents very carefully. And time and again, both I and Mark and others that we speak with don't follow that advice. If you could, you would know that someone who has had development of cognitive failure in their 70s or 80s, that is a risk factor for developing it oneself. Now, let me hasten to add that by no means everyone who has a mother or father who developed Alzheimer's will necessarily get the disease itself. And actually, we have some evidence in society that the new attack rate of Alzheimer's, that is the incidence of the disease, may be declining a bit. perhaps due to better general health care, better nutrition, watching out for other things that cause brain problems like vascular disease. So we're not necessarily, we see a lot of Alzheimer's, there's no doubt about it, but it's not necessarily a true epidemic running away the way that COVID-19 is, for example. And so this disease has been with us for a long time. Genetics is a factor. There are multiple different genes. There are probably many dozens or hundreds of genes that can lead to it. I listed 4 in a table I showed you, and those are particularly noxious. And the one that would matter the most to people who are listening in today would be the gene we call ApoE4. So as I mentioned briefly, apolipoprotein E, ApoE, is a protein that's part of cholesterol particles or lipid particles throughout the body. And it was known for a long time that it was important for lipid transport. It turns out through careful research that ApoE4 is a major risk factor for getting Alzheimer's. Now, let me make one other point about genetics, and then we'll move to the next question. I wouldn't encourage people to run out and necessarily get tested for the genes that I listed or other genes linked to Alzheimer's. First of all, the only one that would make sense for the vast majority of listeners to get tested for would be ApoE, because that is by far the most common gene. The other genes I mentioned, so-called presenilin or the amyloid parent protein APP, those are exceedingly rare. And there the disease arises in the 30s, 40s, and 50s. So for all of us in society, ApoE would be the one we'd like to know about. And in some of the genetic testing services one can send DNA for, they'll let you know that you have an ApoE4, E3, or E2 gene. I don't advise that until there is a treatment. Once a treatment is approved, then we can do something about a genetic tendency, and then perhaps more people will come forward and be tested in an orderly fashion in clinical settings. But right now, I personally don't advise patients and families to get genetic testing. On the other hand, I do advise them that if there's a cognitive problem underway, they should see a specialist.
And the next question is there an age threshold for which you will likely not develop Alzheimer's?
Mark?
Yeah, so I would say that the age, chronological age, how much time you spent on this planet is the #1 predictor or risk factor for developing Alzheimer's disease, and that it continues as one ages. So that it grows in a what's called an exponential pattern. It's not even a linear or a straight line. The curve is up, and so that as one ages, the risk increases. So that I would not say that there is a threshold at which if you reach a particular age, then you're home free. Unfortunately, it is something that correlates strongly with age at that stage. Now, that being said, I think as Dennis was hinting at or talking about directly was there's another concept out there of biological age where, it could be that by doing these changes in your watching your diet, exercising, keeping your mind active, engaging and socializing, for example, those things could be something that people can do, loved ones can do to try to slow down the risk of developing symptomatic disease. And so I think that those things, and I believe the studies there's been some studies and there's further studies going on right now to look at this more carefully. But as far as the way I understand the data, I think that those things would be beneficial to people at all ages. And so I would encourage people to do those environmental activities to reduce the risk of developing these cognitive symptoms or progressing.
Okay, next question is there a relationship between poor sleep and development or progression of Alzheimer's?
Do you want to try that one also?
Sure, sure. No, so there's a it's a bit of a, I think it's a bit of a chicken and egg question. So there's, I think people that have poor sleep do have an increased risk of developing cognitive symptoms, including Alzheimer's disease. There's increasing evidence by labs across the country where the plaques, the A beta, that is the way that the brain clears A beta, seems to be pronounced during sleep, in particularly deep stages of sleep. And so if people have fragmented sleep, then their clearance of these toxins within the brain, including A beta, including tau, is probably reduced. And so that could lead to problems. On the other hand, it seems that patients that have pathology with Alzheimer's disease, also it can be a cause of fragmented sleep. And so it gets to be a challenge there. I would say that in general, sleep hygiene is something that I certainly counsel my patients on, is trying to adapt as good of habits as you can to preserve sleep as best you can. So things like don't watch, no blue lights, or don't watch screens an hour before you go to bed. Try to set a set time, whatever. It doesn't matter to me if you're a night owl or you're an early to bed, early to rise person. That's in part genetically entrained. So that I don't gonna say a specific bedtime, but I do think that there's, whatever works for you, kind of stick to a certain bedtime and try to pay attention to sleep, because I think that will help mitigate changes in cognition for a variety of reasons.
The next question is, are there any connections between diet and slowing the progression of Alzheimer's?
So that's a question that Mark and I and many other clinicians hear every time we see a family or a patient. And the answer is yes and no. The no part is that Alzheimer's is pretty much universal across the globe. And so people with very different diets will develop this disease. It's very prevalent in Asian countries, in Africa, and in Europe. So diet isn't a simple or direct factor that makes it more likely or less likely to get Alzheimer's disease. People with many different diets do get the disease, and the disease looks rather similar in those people, both clinically and pathologically. That is what we see in the brain when a patient dies. On the other hand, the yes part of the answer is that we increasingly believe that certain diets that people in the cardiology field mostly and in the nutritional field have told us are good for heart health, those diets may also be helpful in making it less likely that one would get Alzheimer's, or perhaps more correctly, slowing it down a bit and making it later in life that you might get it. So a heart healthy diet is sometimes also referred to as a Mediterranean diet. And many physicians believe, and the evidence is reasonably good, that people who emphasize the Mediterranean diet style with lots of green leafy vegetables and reds and yellow vegetables and nuts that grow on trees, but not nuts that grow on the ground, like peanuts. Those aren't the right ones. And a certain amount of modest wine consumption and oil, olive oil, those, and fish consumption, those are preferable for keeping a healthy heart. And that means less processed foods, less well-marbled meats. Doesn't mean one couldn't have any of those on occasion, but a weekly diet should emphasize more the qualities of the Mediterranean diet and somewhat less the classical American diet of the 1950s, which was lots of hamburgers and potatoes and things of that sort. So in that sense, diet is not a definite causative factor of the disease. I see patients with very different dietary habits and histories, and they all get Alzheimer's disease. On the other hand, it could be that if you do something about your diet when you're 40, 50, or 60, that could potentially lead to greater brain health, just as it leads apparently to greater heart health.
What age is the average age that someone is diagnosed?
So that is a great question. So the emphasis, I think, is trying to make the diagnosis as early as possible. So that statistically, I think the numbers would be something in the average age is somewhere in the 70 to 75 range, roughly. I mean, but so much of that is dependent on when does the person or the family bring it to medical attention for the person to receive the diagnosis. And then also the level of comfort that physicians have to make the diagnosis. And so I was very encouraged, and Dennis probably played a role in this, but I was very encouraged that all physicians in Massachusetts this year have to get training in Alzheimer's, and that's coming down from the state. And so I know there was some strong advocacy for education amongst physicians for Alzheimer's disease. And I think that will help to bring attention to it, because not only does it, these types of things that we're talking about, changes in lifestyle and hopefully treatments emerging. I think in the history of medicine, we see that the earlier one treats a disease, usually the better the outcome. And I suspect that's going to be true in Alzheimer's. So the fact that we can be able to bring it to the attention of physicians earlier, and those types of mitigating strategies can be implemented, I think that will help. And Dennis even hinted at that it seems that the rate of Alzheimer's might be slightly going down, and maybe that's part of this what's the beginnings of what's happening. But I was very encouraged to see that there's going to be increasing education amongst physicians, and I think that will help them with the level of comfort of dealing with Alzheimer's, because I would completely agree. I wish we had enough specialists to see all of Alzheimer's, but it's possible, or it's not possible, to be honest, that every patient with Alzheimer's gets to see a specialist, at least right now. By helping primary care physicians be comfortable with it and getting people on the right track is going to be an important step to help mitigate the public health problem.
And I might add that about this issue of age, I agree completely with Mark's comments, and that the common age is in the mid 70s or mid to late 70s, but it keeps on happening in the 80s and in the 90s. I had a patient who was actually the wife of a professor at Harvard, where we teach and work, who brought his wife to me when she was 97. And he said that she wasn't doing the 1040 IRS form quite the way she used to. And of course, I couldn't possibly do the IRS 1040 form at any time in my life. She was able to do that. And she also played bridge very well, but she would renege or misbid. And sure enough, I said, well, your wife must be quite a remarkable woman at 97. She does all those things. But when I tested her, she was not as sharp as he led me to believe she had been. And she died eventually 4 or 5 years later at 102. And we found the abnormalities that I showed you in some of my slides of those amyloid plaques and neurofibrillary tangles widespread in the brain. So she handled it quite well. And I think there's no sort of maximum age at which you might get Alzheimer's. It is something that ramps up with life on the planet, time on the planet. It happens in other species, like all the primates we've studied, and in dogs and cats. And so I think the reality is that this is very age related. There's no maximal age. There's frankly hardly a minimal age. The youngest case I've ever heard of was 18 years old, which is unbelievable. But that was a young woman who had a presenilin mutation, a very aggressive presenilin mutation, which is one of those genes that, again, almost no one listening to us today is very likely to have such a gene mutation. They're quite rare. So, but mostly it's in the late 60s, the 70s, and 80s that we diagnose patients.
And our final question this morning is, can you discuss the MIT research about the use of gamma wave light and sound stimulation at 40 hertz as a possible treatment?
Yeah, so this is work that came from a distinguished neurobiologist, Liwei Tsai, at MIT. And she and her colleagues did remarkable experiments in animals, including mice that are engineered to have a mutation in this amyloid parent protein, the APP, that causes them to make too much A beta throughout life. And through a series of different, partially serendipitous experimental manipulations, they found that stimulating the visual system or the auditory system, virtually any sensory stimulus that was repetitive at a certain specific frequency of 40 times per minute, per second, that would lead then to some lowering of their amyloid plaque burden in the brain. So these mice were given a flashing light at a certain 40 cycles per second or 40 hertz stimulus, and that led remarkably to less amyloid over time. And they figured out that that seemed to be due to some activation of microglial cells, which are very important cells in the brain that help control inflammation and clearance of abnormal proteins. And so elevating microglial activity with a flashing light source or a flashing click or a repetitive click would actually be beneficial in mice. And that's gone into patients. Mark and I were discussing that before the session began, and we've each had a patient who's gone into a clinical trial by a small company, Cognito Therapeutics, I think they're called, where Cognito is offering a device that provides repetitive flashing light that patients use once a day or so. I don't know how exactly the trial is going now, but it's a very intriguing physical treatment of sorts that may work by stimulating amyloid clearing cells referred to as microglia. I should say that that's just one example of a lot of different treatments. There are many dozens of clinical trials underway for Alzheimer's. And we should mention briefly that, for example, while we've focused a bit on the amyloid problem, the tau problem, the tangles of Alzheimer's are equally or maybe even more important as an abnormality that leads people to have trouble thinking. And so there are antibodies to the tau protein that are in clinical trials as we speak. There are remarkable new age techniques, type of genetic therapy where you can decrease the level of the gene that makes tau, so-called antisense oligonucleotides, and they might find good use in Alzheimer's. And there are trials underway to knock down the tau gene, not completely, but partially. People have even said that they might want to knock down that amyloid parent protein or APP gene somewhat. So these are new approaches. There's also various other kinds of stimulation approaches to the brain, magnetic stimulation, and others that people are testing to see if they might work for Alzheimer's. My own opinion is that the most likely thing will be the kind of thing that Mark displayed in his exciting new work, that is a small molecule, a pill of sorts, that will do something key to the abnormalities in the brain that will keep those abnormalities from causing a short circuiting of synapses. And also things like aducanumab and the other antibodies that are following it now in clinical trials. Those, I think, are the most likely thing to make a big dent in the Alzheimer process. That is, small molecule drugs and infusion drugs like aducanumab, an antibody. And as Mark said, I also don't have any equity in these companies that make these drugs. It's important to mention. All right. Are there any other questions you'd like us to answer?
No, that's our final question. Just if you both have some final thoughts, we can wrap it up.
Good. So I think there's a few things we can still exchange. Mark, is there anything else you'd like to tell the audience about your experience managing the Alzheimer problem?
No, I think that I appreciate everyone coming out on a Saturday and to try to learn more about this important problem, and for all of your help and assistance and support, both with your patients, the loved ones, as well as trying to help move the science forward so that we can get to therapies. And in particular, as Dennis was emphasizing, the disease modifying therapies, so we can actually be slowing down the disease. And so we are, as researchers, I can say that we're very grateful for all of your support, and as physicians, we tip our caps to all the families that are dealing with it. It's an amazing, it takes an entire team to take care of one patient, and we are constantly inspired and amazed by all of the humanity and all of the care that we get to witness as trying to help solve this problem. So thank you for your time today.
And I'll add to that we're particularly grateful to the McCourt Foundation for sponsoring this public lecture for so many years. We've done this for many years in person, and now we're doing it virtually. And I think it's a very efficient way to do it, to reach a great many people. And they don't have to drive their cars to the local hotel where we give this talk. And we're very happy that Brian McCourt and his brothers and others in the McCourt Foundation have done so much to heighten the interest in not only Alzheimer's disease, but also multiple sclerosis. There'll be a session on that, and ALS now, and just be really concerned about driving brain research forward because it's such an enormous, important point. I'll also mention two other scientific points. One question I've always gotten over the years that doesn't seem to go away is whether Alzheimer's could be caused by aluminum or by some other metal ion. And we don't have evidence that that's a true causative factor. There's metal ions in everything that we contact and eat, the water we drink. And so metal ions are ubiquitous in our environment. And it's not out of the question that some metal ions could contribute a little bit to make things worse. But by and large, there's been very little evidence that metal ions, and particularly aluminum, which was brought forward when I first got into this field 3 decades or more ago, that's never really panned out, to use a bad pun. There hasn't been evidence that aluminum is an issue, but I know that that's still thing that people bring up to me. So it's not a matter of avoiding anything particular in the environment that would lead you not to get Alzheimer's. We just don't have evidence that specific environmental toxins or metals are truly causative of the disease. And then I'll also mention as a final point that we feel that patients and their families should be aware that there's no place in the world currently that has a bona fide, proven treatment for Alzheimer's disease. So you don't need to flood the airways or get on the internet to try to figure out where's the doctor who has that Alzheimer's treatment that I can help my mother with or my father. That doesn't exist. You'll read in the papers what happens with the FDA and the European Medicines Agency, the EMA, and other agencies in terms of how they don't or do approve emerging treatments that have been in clinical trials. But there's no one out there, certainly including Mark and myself, who has a magic bullet for Alzheimer's. So I think it's very important to accept that reality and follow the news. The greatest source, I think, of information, and beyond even what the McCourt Foundation has helped with, is the Alzheimer's Association, which is in the United States and is around the world now. So the Alzheimer's Association has lots of information, and that's where you can find the latest word. And of course, you can see it in your newspapers and on when there is a treatment that anyone feels could be helpful for Alzheimer's, it will be front page news, and you won't have any trouble hearing about it. Right now, we really don't have such a treatment beyond the ones that are in clinical trials. So we do encourage people to enroll in clinical trials if they've seen a specialist and they're able to be directed to a clinical trial for Alzheimer's. And that's my final remark. And again, I want to thank Mark for joining me and thank the McCourt Foundation for sponsoring this. Thank you so much. Have a good day.
Thank you very much.
The day I found out I had a progressive like sensory event where basically my hand and foot, I woke up and it was just pins and needles. And because I was about to finish school, I could diagnose these things. And I had a really strong understanding of like the neuromusculoskeletal system. And so pins and needles is pretty much nerve, almost always. And so I was like, well, that's not great. But kind of ignored it, and it progressed to the entire left side of my body. And that's when I went to the hospital. They said they wanted to get an MRI. And as I'm being loaded into an MRI, for whatever reason, he's like, yeah, we're running a scan for MS. And, you know, they shove me in the tube and you're totally still and you've got a cage over your face. And in my head, I was like, I started like doing the math and I was like, this is not good. Like I have MS. Like I just knew at that moment. And, you know, I don't think it really hit me the next day until I had to tell my mom. And my mom's a nurse. She's very well educated. And, you know, having to like sit her down, I think she took it much harder than I did. And then I was just really angry. I was, you know, I was pissed. Through the McCourt Foundation, I think it's the understanding that that this organization is completely selfless. I think hope is really important for people, and there's the opportunity that like one day maybe I'm cured of this, you know what I mean? And I tell the story like this one time I had MS versus I have MS and will always have MS.
I'm a neurologist at the Massachusetts General Hospital, and I specialize in multiple sclerosis. And I've been at MGH now for just a little over 10 years. So my research focuses on a couple different areas. One is related to clinical trials. So looking at new therapeutics in multiple sclerosis. I also have a research lab that is devoted to imaging. So looking at new ways to assess multiple sclerosis, ultimately to come up with biomarkers that we can use in those clinical trials. I saw that there were some big opportunities to improve our treatment of the disease. And MS is also unique in the sense that most people are diagnosed at a relatively young age, in their 20s or 30s, a time when they're really in the productive years of their life. And I felt like this was really a condition that, as a physician, I felt like I could really make an impact in people's lives. partnering with the McCourt Foundation now for I think more than 5 years. And I think it's been really valuable to making an impact on our ability to treat people with neurologic disease. And so myself as an MS specialist, I can tell you that really some of the most valuable partnerships allow us flexibility in really focusing research funds where they're needed most. And so I think that there's a big advantage of being able to say, here is an immediate need or an immediate question that needs to be answered, and to be able to do that as quickly as possible. So that's just one example of how this partnership with the McCourt Foundation has been just really valuable and allowed us to make impacts immediately.
My dad, I'm an only child. I grew up in the house that my dad grew up in. And he's just, I know I'm biased, but he's one of those really special people who touch a lot of lives. And I've really realized that since, he was a police officer in the town that I grew up in. He would just, throw off his gun belt, play basketball with kids. He just was an inspiration and still is. And his positive outlook on life, I try to kind of channel when I'm having a tough day. So always went the extra mile to help people. He's inspiring to me because he was always so positive and had the strongest kind of mental ability of anyone. Like, he could push himself through anything. And he inspired me as a child in many things, but running was one of them. He got me into it. He ran a bunch of Boston marathons, and I grew up on the route, so I got to watch him. Looking back, there were probably some signs, but he got it. He was diagnosed with early onset dementia. They called it semantic dementia, so it's a loss of words initially, and then it kind of flows more into Alzheimer's. He started to kind of describe around things, and that's when we kind of, he wouldn't be able to think of a word like sweater or something like that. And he'd say, the thing you wear to keep you warm. Receiving the diagnosis, though, was really hard. They first diagnosed it as depression, and we were like, he's the least depressed person we know. But I think it was probably in his head, it was tough because he didn't know what was happening to him. Again, I always wanted to run the marathon with my dad, but that didn't happen. And I was fortunate enough to find McCourt Foundation, who had a team, invited me on. I raised more money than I ever thought I could raise. I raised $19,000. that year, and the way their family is so invested in helping, and it was amazing. And I look back and I think, even though the weather was terrible the year I ran, it was one of the best experiences of my life, and one of those big bucket list goals that I always had. And I knew my dad would be so proud. He definitely helped me get through those latter miles of heartbreak and hometown stuff.
The Department of Neurology is part of Cedars-Sinai Medical Center, and we think of ourselves as neurosciences, so that includes both our neurosurgical partners as well as our neurologists. We work together. So we have world-class neuroscientists who are using an opportunity that we get from epilepsy surgery to really understand fundamental ways that the brain works, and in particular forms memories. And as you know, this is a key area for dementias, for Alzheimer's disease. And so we're doing work with patients who are undergoing depth electrode placement for possible surgical resection. And so they're having recordings done. And while they're sitting on the ward waiting to have seizures that are informative and help with their surgical planning, they're also doing experiments, and they're having recordings done. Fundraising is so important. I think about it as like the rocket fuel that gets things going. It allows you to do things that are maybe a little bit riskier, but also have the biggest payoff. So when we're trying to really do unique, kind of new and risky things, having philanthropy allows us to really do that crazy experiment, take that risk. So in those early years, it's really critical that we have access to funds so that we can really support these really exciting people. And so if we can really raise the level of care that people are receiving and raise access throughout the Los Angeles area, it's really the goal of Cedars as a medical center, and make all of the cutting edge therapies that we are working on available to the widest number of people across Los Angeles. So that's the thing that gets me really excited when I'm thinking about what we're working toward, because we have this opportunity to really raise the standard of care, not just for the people who are here at our medical center, but throughout the whole Los Angeles area.
Meritz-Kovich. I participated in the Tour de South Shore many times on Team MGH. We've raised money to support research that TMF supports. I've never run it or biked it. I've just walked it, but it's a great event. What I love about TMF is they support several disorders, several brain disorders that have overlapping biology. And by doing that, they bring teams together to solve these diseases that affect so many people. So I'm Chief of Neurology at Mass General Hospital, and I also run our ALS or Lou Gehrig's center. So in my chief hat, it's really about promoting young investigators and taking great care of patients and really trying to solve some of these diseases. With my ALS hat, it's really about how do we innovate and get treatments developed for people with that disorder as fast as possible. ALS stands for amyotrophic lateral sclerosis. It's a really awful illness. It's one of the worst ones out there, where people in their mid-50s often will start to lose ability to use their hands or to walk or to breathe and talk. It's a fatal illness. And really, we don't have a lot of good treatment options right now, but there's a lot of research, and we need those funds to kind of push those great ideas from the lab to patients to trials. Our clinic is all about hope. It's about what can we do for you today, and what are the options, and making sure people have options for trials, for compassionate use, that they know everything that's going on, because there really is a lot of hope out there, and it's important for patients to go to doctors and teams that know what's going on and can give them options. In ALS, I think huge hopes of a cure, I hope, if I can say that word, for the genetic forms really quickly, really soon. The technology to block gene mutations in the brain and people is there. There's already trials going on, and if we can stop the cause of it, I think there's huge hope we can really stop the illness. For the other 90% of people who don't have the genetic cause, I still have a lot of hope, but it might be just a little farther away.
The day I found out I had a progressive sensory event where basically my hand and foot, I woke up and it was just pins and needles. And because I was about to finish school, I could diagnose these things, and I had a really strong understanding of the neuromusculoskeletal system. And so pins and needles is pretty much nerve, almost always. And so I was like, well, that's not great. But kind of ignored it, and it progressed to the entire left side of my body, and that's when I went to the hospital. They said they wanted to get an MRI, and as I'm being loaded into an MRI, for whatever reason, he's like, yeah, we're running a scan for MS. And, they shove me in the tube, and you're totally still, and you've got a cage over your face. And in my head, I started doing the math, and I was like, this is not good. Like, I have MS. Like, I just knew at that moment. And, you know, I don't think it really hit me the next day until I had to tell my mom. And my mom's a nurse. She's very well educated, and, you know, having to like sit her down, I think she took it much harder than I did. And then I was just really angry. I was, you know, I was pissed. Through the McCourt Foundation, I think it's the understanding that that this organization is completely selfless. I think hope is really important for people, and there's the opportunity that, like, one day maybe I'm cured of this, you know what I mean? And I tell the story like, this one time I had MS versus I have MS and will always have MS.
I'm a neurologist at the Massachusetts General Hospital, and I specialize in multiple sclerosis. And I've been at MGH now for just a little over 10 years. So my research focuses on a couple different areas. One is related to clinical trials. So looking at new therapeutics in multiple sclerosis. I also have a research lab that is devoted to imaging. So looking at new ways to assess multiple sclerosis, ultimately to come up with biomarkers that we can use in those clinical trials. I saw that there were some big opportunities to improve our treatment of the disease. And MS is also unique in the sense that most people are diagnosed at a relatively young age, in their 20s or 30s, a time when they're really in the productive years of their life. And I felt like this was really a condition that, as a physician, I felt like I could really make an impact on people's lives. Partnering with the McCourt Foundation now for, I think, more than 5 years. And I think it's been really valuable to making an impact on our ability to treat people with neurologic disease. And so myself as an MS specialist, I can tell you that really some of the most valuable partnerships allow us flexibility in really focusing research funds where they're needed most. And so I think that there's a big advantage of being able to say, here is an immediate need or an immediate question that needs to be answered, and to be able to do that as quickly as possible. So that's just one example of how this partnership with the McCourt Foundation has been just really valuable and allowed us to make impacts immediately.
My dad, I'm an only child. I grew up in the house that my dad grew up in. And he's just, I know I'm biased, but he's one of those really special people who touch a lot of lives. And I've really realized that since, he was a police officer in the town that I grew up in. He would just, throw off his gun belt, play basketball with kids. He just was an inspiration and still is. And his positive outlook on life, I try to kind of channel when I'm having a tough day. So always went the extra mile to help people. He's inspiring to me because he was always so positive and had the strongest kind of mental ability of anyone. Like he could push himself through anything. And he inspired me as a child in many things, but running was one of them. He got me into it. He ran a bunch of Boston marathons, and I grew up on the route, so I got to watch him. Looking back, there were probably some signs, but he got it. He was diagnosed with early onset dementia. They called it semantic dementia, so it's a loss of words initially, and then it kind of flows more into Alzheimer's. He started to kind of describe around things, and that's when we kind of, he wouldn't be able to think of a word like sweater or something like that, and he'd say, the thing you wear to keep you warm. Receiving the diagnosis, though, was really hard. They first diagnosed it as depression, and we were like, he's the least depressed person we know, but I think it was probably in his head, it was tough because he didn't know what was happening to him. Again, I always wanted to run the marathon with my dad, but that didn't happen. And I was fortunate enough to find McCourt Foundation, who had a team, invited me on. I raised more money than I ever thought I could raise. I raised $19,000 that year. And the way their family is so invested in helping, and it was amazing. And I look back and I think, even though the weather was terrible the year I ran, it was one of the best experiences of my life, and one of those big bucket list goals that I always had. And I knew my dad would be so proud. He definitely helped me get through those latter miles of heartbreak and holding down the stuff.
The Department of Neurology is part of Cedars-Sinai Medical Center, and we think of ourselves as neurosciences, so that includes both our neurosurgical partners as well as our neurologists. We work together. So we have world-class neuroscientists who are using an opportunity that we get from epilepsy surgery to really understand fundamental ways that the brain works, and in particular forms memories. And as you know, this is a key area for dementias, for Alzheimer's disease. And so we're doing work with patients who are undergoing depth electrode placement for possible surgical resection. And so they're having recordings done. And while they're sitting on the ward waiting to have seizures that are informative and help with their surgical planning, they're also doing experiments, and they're having recordings done. Fundraising is so important. I think about it as like the rocket fuel that gets things going. It allows you to do things that are maybe a little bit riskier, but also have the biggest payoff. So when we're trying to really do unique, kind of new and risky things, having philanthropy allows us to really do that crazy experiment, take that risk. So in those early years, it's really critical that we have access to funds so that we can really support these really exciting people. And so if we can really raise the level of care that people are receiving and raise access throughout the Los Angeles area, it's really the goal of Cedars as a medical center, and make all of the cutting edge therapies that we're working on available to the widest number of people across Los Angeles. So that's the thing that gets me really excited when I'm thinking about what we're working toward, because we have this opportunity to really sort of raise the standard of care, not just for the people who are here at our medical center, but throughout the whole Los Angeles area.
I'm Brian McCourt, president of the McCourt Foundation, and we'd like to welcome you all here today for the first ever virtual McCourt Foundation educational update. We've got a fantastic lineup of physicians that we'll be presenting today. Physicians that are not only top in the country, but top in the world in their respective disciplines. We're excited about having you all here and hosting you, and would also like to thank all of our sponsors that are making this possible. But I'd like to especially thank our presenting sponsors, Bristol Myers Squibb and UBS Financial, as well as our silver sponsor, Sanofi Genzyme. But I would like to thank all of you for being a part of this day. This has always been one of our favorite and most impactful programs, and it's all because of you. So enjoy the program. I'd like to now introduce Stephen Sypek with UBS Financial.
Thank you, Brian. And thank you for joining us today, and welcome to the McCourt Foundation Educational Symposium. My name is Steve Sypek, a financial advisor with UBS Financial Services here in Rockland, Massachusetts. I've been friends with the McCourt family for many years and personally involved with the foundation for over 20 years. I too have been impacted by neurological disease, and that my mother passed away from Parkinson's 5 years ago this year. I am excited for today that you will be hearing from the top doctors and researchers from Massachusetts General Hospital, Brigham and Women's Hospital, and Cedars-Sinai Medical Center on their progress and developments in the areas of multiple sclerosis, Alzheimer's, and ALS research. We all know the challenge that individuals and their families face in dealing with neurological diseases. And that is why I believe the McCourt Foundation focus on making things better by supporting research, providing education, and developing strategic health-focused partnerships will one day lead to a cure for many of these diseases. As a financial advisor, I know the challenges that these patients and their families face in planning for the unexpected and in dealing with the emotional, physical, and financial challenges. We believe that the financial services industry can help families plan for those unexpected circumstances, and also help support the critical research and awareness in the areas of neurological diseases. And that is why UBS is excited and proud to support the McCourt Foundation in their great work and their mission by sponsoring today's educational update. Thank you for joining us. I hope you find these sessions helpful and that they will continue to inspire and empower you and your loved ones in making things better each and every day. Enjoy the upcoming update.
Hello. It's a pleasure to be with you this afternoon for the McCourt Foundation Educational Update. My name is Eric Clowder. I'm a neurologist at the Massachusetts General Hospital, and I think we've got a great 90 minutes of talks and Q&A planned for all of you today. And I'm joined with a number of colleagues who have just been introduced, and I'll take some time to personally introduce each of them as we move through the talks and Q&A today. First off, I am going to give a 15-minute talk on work that we have done at MGH that has been supported by the McCourt Foundation, looking at COVID-19 and how that relates to people with MS and various treatments that people with MS are on. And then we'll use that as a branching point to talk about COVID-19 as it relates to vaccines then later in the Q&A session. So if you give me just 1 second, I will pull up Okay, excellent. So what I'll discuss for the next 15 minutes, as I mentioned, is the COVID-19 pandemic and how it relates to MS and treatment. So as I mentioned, the research that I'll discuss was supported in completeness by the McCourt Foundation. And then here are my relevant disclosures that relate to research funding and consulting. So at the beginning of the pandemic, and we're going back to March of 2020, really, when this started to become a really big issue in the United States, there were a lot of questions that were circulating by my patients. It's sort of interesting how how questions have evolved over the course of the last year, but really initially, some of the important things that people were thinking about were, does my diagnosis of MS put me at a greater risk for infection? Knowing that that many patients are on either immune modulatory or immune suppression treatments where infection can be a side effect. And then just with the variable outcomes of COVID-19, one of the important questions was, given my diagnosis and treatment that I'm on, does this put me at an increased risk of more severe outcomes? And obviously that's really with this pandemic, what we're concerned about, or the effect that it can have, leading to hospitalization, and and the fact that it does have a low mortality rate. And some of these questions that I mentioned have evolved over time. So, for instance, being on treatment, would that affect the duration of protection that you might have if you've had COVID? And now the question, I think, has evolved to, if you've been vaccinated, does treatment affect immunity? And would that put someone at a greater risk for either reinfection or infection after being vaccinated? So the McCourt Foundation tried to bring in Dr. Anthony Fauci to give the talk today, but he was booked. So you're all stuck with me as a result of that. And unfortunately, I don't have gray hair, but I'm gonna do my best to lend some credibility to this issue this afternoon. So there have been a number of registries that have been set up. There's one that was organized by the National MS Society. I think a nice one that's been published is from a group of neurologists and MS doctors in France. And this is the lead author on this is Celine Luop, who actually trained at MGH a number of years ago. And so they looked, in this case, in registries, we're looking at patients that have had COVID-19 largely. Most of these registries are set up in that way. So the registries were, I think one of the nice things is that early on, registries that were happening in various countries made some effort to collect the same information so that eventually this could be pooled. But here I'm going to just show one example here, in part because the conclusions actually have been very similar in other registries as well. So one of the comforting things I think right away was that largely the outcomes that we were seeing in people with MS were very similar to what we were seeing in the general population. And so I think this was largely reassuring, and lent itself to the fact that there may be actually some treatments that people with MS that were on that actually provided some protection against severe disease. And it's also possible that other treatments, depending on how they suppress or modulate the immune system, could put people at an increased risk of more severe disease. But here we see actually in this graphic that as it turned and we're looking at the worse outcomes were in the darker blue, that actually people that were not on treatment in this case were more likely to have more severe outcomes. In pooling data, there has been some suggestion that people on the B cell depleting monoclonal antibodies, medications like ocrelizumab or rituximab, may have an increased risk of hospitalization or needing ventilation. But mortality rate largely has been similar between treatment groups. And this graphic here, I think nicely shows what are some of the risk factors for severe outcomes. And so a number of them are very similar to what we've seen just in general population-based studies. So one of the greatest risk factors is age. And with each decade that you're older, there's an increased risk of more severe outcome. We've also seen various comorbidities related to cardiac disease, underlying pulmonary disease, diabetes as being risk factors, obesity. But a nice thing that the registries have done is that they've been able to identify some risk factors just within the group of people with MS that participated or were included in the registry. And in which case we see that people with progressive disease were more likely to have a more severe outcome, people with higher disability level. And in this case, though, we're seeing that actually treatment, in this case, lowered the risk of severe outcome, which may be because people that were older and had progressive disease were less likely to be treated. So I think the interesting thing about this particular virus is that, in particularly early on when testing was poor, was that we could identify a group of people that had positive testing with the nasal swab PCR. But really that wasn't a completely representative group of everyone that had COVID-19, either because testing was poor or just because there were milder or asymptomatic cases. And so in fact, if you look at what actually represents people that had COVID-19, we see that that what we initially thought was actually a subset. And so this was illustrated nicely in some early studies looking at antibody testing or serology. So essentially, instead of focusing on those that had been tested, if we just sampled for whether people had had some immune response or exposure to the virus, we saw that this was, in some cases, more than tenfold higher than what we were seeing with the actual case counts. And so this was the idea for this particular study that I had mentioned we embarked on with support from the McCourt Foundation, looking at antibodies to the SARS-CoV-2 or COVID-19. And there were a couple of questions that we felt we could answer perhaps in a better way by looking at antibodies as opposed to registries, which may be biased to some extent based upon who gets reported to the registry. And so in this case, we looked at 329 consecutive people with MS that resided in Massachusetts and received their care at either MGH or Brigham and Women's Hospital. And as a comparison group, then we also, knowing that a risk for exposure was high within a household with this virus, we also enrolled cohabitants of those people with MS. And so not everyone had a cohabitant that participated in the study, but we did enroll 209 cohabitants in this case, one per, potentially no more than one per household though. And then to supplement that, then we also looked at sort of outside of that group that was enrolled just as a general look at antibodies within our population, an additional group of people that had confirmed COVID-19 and also their cohabitants so that we could do some additional analysis as well. And early on, I think one of the things that we discovered was that it was, I think, a real challenge, and also there was a lot of apprehension around accessing the hospital during the early part of the pandemic. So we designed this study so that it could be done completely remotely. And so in this case, we sent out dried blood cards to participants, and they pricked their finger and gave little drops of blood, sent that back into us so that we could test for these antibodies. This is Galit Alter, a collaborator of mine who designed this, this antibody test, which has about 90% sensitivity, meaning that if there were 10 people that actually had COVID-19, this test was going to generally miss one, but it was going to pick up 9 out of 10. But it had very high specificity, meaning that if a test came back positive, we were nearly certain that that represented someone that had COVID, as opposed to a false positive, which you wouldn't, you would really want to prevent in such a test. We did the collection, as I mentioned, very specifically focusing on just the state of Massachusetts. And in that way, we could compare it against population rates of positive testing. But we also had a pretty reliable data from knowing what the case counts were in the state. And so in this case, you can see we started testing kind of on a rolling basis as we were recruiting participants, but largely it was done after the first wave of in Massachusetts. So testing really in the months of June through August in this case. And what we found, some of the highlights from the results were that there was a very low percentage of people that that tested positive. So you can see in the square box here, only 11 out of 329 people with MS, or 3.3%, had positive antibodies after that first wave. And based upon the case counts that that we were seeing, where it was about a little over 1 to 1.5 or 1.7% of Massachusetts had positive PCR tests. We actually, if you apply that maybe tenfold increase, we're actually seeing a low percentage of antibodies in the group that participated in the study. However, it was interesting that in the cohabitant group, it was a little bit higher. So even within that household, there was a higher percentage of cohabitants that had antibody positivity. And we can talk a little bit more about what that might mean. But it was sort of interesting in the cohabitant group, of the 34 people that had a PCR test at some point, either because they, had it as part of screening or had some concerning symptoms or exposure, none of the cohabitants actually had a history of a positive PCR, and only 2 of the MS participant group did. We see here that the percentage of, if we look at either the people that tested positive with PCR or antibodies, in this case, there was only a small percentage of people that were symptomatic. So in this case, only 38.8 in the MS group, but only 10% in the cohabitant group. We focused then on some of these cases where there was discordance within a household. So cases where one person tested positive, but then the cohabitant tested negative, or vice versa. In this case, there were 12 of those such cases. And of those, 8 of them were situations where the participant with MS in the household tested negative, but their cohabitant tested positive. And then focusing even in on those 8 situations. Of those 8 people with MS that had negative antibodies in that case, the 5 out of the 8 were on disease-modifying therapy, 3 on ocrelizumab, 2 on interferon, and so one of the things that you might postulate in that case was, well, maybe the cohabitant, was out, more likely to go out and get groceries, or go to work every day, or that type of thing. Or the other possibility is, well, perhaps that person, the cohabitant, had some symptoms or were able to self-isolate a little bit better. I guess the argument against that was that in these cases, none of the cohabitants actually had any symptoms. So it would be difficult for them then to recognize that they needed to self-isolate, and none of them tested PCR positive either. So that's perhaps not a good explanation for this finding. Going on to look at, now supplementing with another group of people that had a positive PCR test, what we found was that when we looked at antibodies after the fact, and this wasn't, there wasn't a standard period of time that we waited until doing antibodies, although we did wait at least 3 weeks after their symptom onset. In that case, we saw that 25% of the people with MS had antibodies afterwards, and of the cohabitants, and this is regardless of whether the cohabitants also tested positive or not. There were 15 in this case. Of the 24, 15 had cohabitants participating, and 60% of the cohabitants had positive antibodies. So we do see a statistically significant difference there. So in conclusion, from this study, we saw that the antibody prevalence was overall very low after the first wave in Massachusetts. But it was interesting that there was a discordance between groups that we might even discuss a little bit in the Q&A session as to what people think could be the reason for that. But it suggests that perhaps either these antibodies were that the antibodies response was less robust in people with MS, or perhaps that they were less persistent over time. I think one of the things that is a caveat that I think is something that's also worth thinking about is that in this case, we're looking at the antibody, or what we call the humoral immune response. But in this case, we didn't test whether you had the cellular immunity, meaning the cells that once they did come in contact with the virus at another point in the future, would be able to be potent enough to kill the virus. So it's a pleasure to be able to share some of this data, and I am certainly thankful for the McCourt Foundation for supporting the study. This was a really great example of how identifying a real immediate and specific need to answer questions was able to be addressed due to the support from the foundation. So thank you. And following that talk, we have an additional talk from Maria Houchins. Maria Houchins is an associate professor of neurology at Harvard Medical School, and is the director of the Women's Health in MS program at Brigham and Women's Hospital. And Maria is going to give us a talk on an update on treatment in MS, including the FDA-approved treatments, and some of the treatments that are in the pipeline in clinical trials. So please go ahead, Maria.
Thank you so much, Eric. I certainly appreciate being here this Saturday, and it'll be a little bit of a challenge to squeeze all this interesting information in 15 minutes time or even less, but I'll do my best, and we might skip a few things just to be able to stay on track so we can have time to answer your questions. So how do we decide, right? So it's an interesting conundrum. We have so many meds. We're so lucky in this field that we have a lot of therapeutics to really offer our patients a lot of choices now. How do we make those decisions, and what is coming in the pipeline? There are some of us that are really looking forward to some of the medications that might be approved in the next few years to help our patients. So when we think about MS treatments, there are several ways we can classify them, right? So we can classify them by how they're delivered to the body. We can classify them by how effective they are, mild, moderate, or superior efficacy, by side effect profile. And we can also classify them by the type of MS that they tend to work better on. And so how do we make treatment decisions, right? So we think about efficacy, of course. We think about side effects and monitoring needs for our patients. We think about what we know about adherence and follow-up. That's important as well. And what kind of dose options we have, how easy it is to stop and start treatment. And I would add now something that Dr. Klaveter just talked about is in the time of a pandemic, we also have to consider, how much of an immune suppression or a change in immune response to either the virus or the vaccination against the virus are we expecting without treatments. At least for right now, that's more important than previously. This is just a quick visual for you to remind how lucky we are again. So in the early 1990s, we had, one treatment. It was, well, prior to that, we had no treatments, right? In the early 1990s, beta seron came around. There was a lottery, and it was very difficult to get on that. And then over the next few years, we've developed several additional injectable treatments, and then natalizumab came about. Then we got fingolimod as a first oral treatment, and then additional oral treatments came out. And then you could just see how the fields exploded. And there are different therapeutic targets and different treatment options, which ultimately keep many of our patients, stable and doing well today. So let's just again quickly talk about how we classify the treatments, first by the method of delivery. So in terms of injections, injectable treatments, there are traditional ones that we used to consider actually the first line therapies, and they include interferons, right? So there's Avonex, beta seron, Xtavia is a generic, glatiramer acetate, Glatopa, and then Plegridy, Rebif, and then another treatment, which is still classified as an injectable, but is in a different category based on efficacy results in trials, is Kesimpta or ofatumumab, which was recently approved. We can talk about that in a bit. Then there are oral treatments, right? So fingolimod or Gilenya was the first to arrive. And then after that, we've got Tecfidera, dimethyl fumarate, and then teriflunomide, Aubagio. And today we have several different formulations of the fumarates. We have diroximel fumarate, which is Vumerity. We have monomethyl fumarate, you can see on this list here. And then Mavenclad, cladribine is a more immunosuppressant treatments. And then ozanimod and siponimod, I should say, siponimod and ozanimod in terms of how they came to market. By the way, anytime in any oral med, you see this ending, right? MOD, M-O-D, you know that they belong to the same class of drugs called S1P receptor modulators. And again, it's just helpful visual to remember how to think of it when you see a generic name of a med. And then we have infusions. Infusions, Tysabri, natalizumab came first, and then alemtuzumab, Lemtrada, and ocrelizumab or Ocrevus, and rituximab, although not specifically FDA approved, has also been used prior to ocrelizumab approval for similar groups of patients. And then novantrone or mitoxantrone is not really used anymore, but it's available. It's still on the list as an infusion therapy. So another way to classify treatments is based on how they work, right? There are some immunomodulating meds that don't suppress immune system necessarily, but change the way that immune system works. And all of the injectables of the first generation interferons, glutaminyl acetate, belong to this category. Terflunomide, which is also a cell depleting agent, is considered to be an immunomodulator in addition. Then there are anti-trafficking agents, and they prevent white blood cells from getting into the circulation or into the organs. In our case, the important organ would be, of course, the brain, the spinal cord, and the optic nerves by various mechanisms. And the ones that we have currently are natalizumab and fingolimod, and then there are several others in development. And then there are immune system depleting agents, which commonly are known as immunosuppressants. And those include cladribine, mavenclad, ocrelizumab, rituximab, alemtuzumab, and now ofatumumab as well, Kesimpta, and several additional treatments in development. And the first, that cyclophosphamide here is not an FDA-approved drug, but we've used it off-label for many years, certainly prior to the current medications becoming available as an immunosuppressant and effective therapy in multiple sclerosis. So when we decide how to treat a patient, there are two ways to think about it. One is certainly known as a branching tree logic, where you start, a certain lower level treatments for appropriate patients, perhaps, and then as the disease changes or as a patient change, the patient symptoms change or relapses and such, you would then escalate, right? You would go to higher and higher and higher efficacy. This is one way. And another way is the hammer and nails logic, which is implied that if you have an illness, you diagnose an illness, and you can really hit it hard, quote unquote, from the very beginning and prevent, hopefully, downstream effects that then eventually would result in disability progression. And so there's a school of thought that suggests that you perhaps want to use more effective treatments right off the bat, even in patients who might not be as sick initially, and then potentially later either not treat or perhaps de-escalate treatment to less, heavier, if you will, medications. And depending on who you see, depending on neurologist, depending on your preference a lot of the time as well, either one or the other approach or some combination could be utilized. So the factors that influence how we think about treatment decisions, right? There are medical considerations and then there are patient considerations. Medical considerations, disease burden, which really means three things. We look at relapse rate, we look at MRI lesions, new and active, and we look at disability progression. And then also patient considerations. What is the lifestyle? What are the treatment expectations? What is the patient able to do? Can they take a pill every day? Can they take a pill twice a day? Can they come to the hospital once a month to get treatment? And so on and so forth. The support systems, and of course, on this list now, on the scale now, would also be COVID and potential other future infectious illnesses. So to talk now specifically about some of the newer medications that came to market. Remember, we said MOD, is S1P receptor modulator. So currently there are 4 on the market. The first one that came out, as we mentioned, is fingolimod. It's hard to keep them kind of straight. So I'm going to point out specific things that are a little bit unique to each of these 4 medications, because they're fundamentally quite similar. So fingolimod, siponimod, ozanimod, and ponesimod. Ponesimod is going to be, I don't know if it was already approved or it's going to be very shortly approved. So fingolimod, the important thing to remember about that is it's approved in children. It's the only pill that's approved for use in children with multiple sclerosis. Right, siponimod is the one that has the best efficacy of the class for treatment of secondary progressive MS. So that's something that's helpful to remember for that. ozanimod, was studied in terms of the cognitive effects, the positive cognitive effects on patients, and it showed good efficacy and good benefits on cognitive processing speed tasks, which is something that tends to be more affected in our patients on the sort of cognitive testing panel. And ponesimod in trials showed significant effect on fatigue. So they looked at different symptoms in addition to the ones that we showed, relapses, MRI disease, and disability. They also looked at some of the specific symptom benefits. And they found that fatigue was the one symptom with ponesimod treated a group of patients that showed significant benefit. Important thing to remember about this class of drugs is that the S1P receptor, there's a group of S1P receptors, 1 through 5 or 6, and they're distributed depending on the subtype. They're distributed throughout the body. They're not just unique to the brain and the spinal cord. So from that, you could sort of understand a little bit better the types of side effects or types of biologic effects that you would expect depending on how specific these treatments, these compounds are. Do they affect all of the subclasses of the S1P receptors, or do they preferentially affect one or the other? And you could, if you speak with a neurologist, you might want to ask for a little bit more information or clarification if your neurologist is considering one of these 4 treatments for you. Ocrelizumab and ofatumumab are similar compounds. They affect the B cell function in slightly different ways. They're both effective. Ocrelizumab is an infusion treatment that's labeled to be used once every 6 months. It showed good efficacy in trials, both in the relapsing patients as well as in primary progressive patients. The efficacy was, better, and it's also easier to measure by far in patients with relapsing MS. With primary progressive MS, so it was the first drug that showed any efficacy. So that's the reason that this particular compound was approved for both relapsing patients as well as PPMS patients. In terms of ofatumumab, this is a compound that's administered monthly, subcutaneously. Works again quite similarly to ocrelizumab in terms of the biology of it. It's a slightly different molecule, but fundamentally also depletes the B cells, CD19 and CD20 positive cells. Again, depending on the doctor's recommendation and patient's preference, either one or the other treatment might be chosen for the right type of situation. This one, obviously, you don't have to go to the hospital. It's a little bit easier to manage, to inject at home. And it also showed very good efficacy in clinical trials. The company, I think Novartis makes this one, the company did not specifically study it in primary progressive patients. So if a doctor has, a primary progressive patient who needs to be on this type of therapy, then ocrelizumab, it really remains the one that can be used. So let's just quickly, again, for the name recognition's sake, as well as for some sort of, maybe a quick discussion about compounds that are in clinical trials, let's talk about what's out there and what might be coming to us in the next few years. So the first one I highlighted in yellow here is masitinib. Just like we looked at the mod at the end of the words, if you see MAB or NIB at the end of the medication name, you would know that these are some kind of monoclonal antibodies, most likely, right? That's just the way that the drugs are named. So NIB or MAB would be monoclonal antibodies. So masitinib is a treatment. Many treatments come to multiple sclerosis from oncology world. So this is one of these treatments. It came to us from oncology, or is coming to us, hopefully, from oncology world, cancer world. And this one is interesting because it blocks a particular cell division in a particular way. So it seems to primarily target mast cells and microglia. And what's interesting about this drug is that it has shown early efficacy in earlier phase trials in progressive MS. And it's currently in trials for progressive MS, both primary and secondary progressive, right? So the results from earlier clinical trials are shown here. So it was associated with a fairly good, it's a little bit difficult to understand here, but this is the confusing part of how the clinical trials are described. So 39% increase in reduction, right? So it's kind of hard to wrap your mind around that. So it's an increase in the probability of reduction of disability progression, right? So hopefully you can kind of see how it goes. So you would progress at a certain rate, and if in trials, and if a patient or a subject was on this drug, they had an almost 40% greater chance of not progressing or even improving. Right, so this is a very good number. It's an early study, but this is still a very good number. And then also, patients on this drug had a significant 42% less risk of what they call first progression. So if they haven't progressed yet, they're going to be less likely to progress given this drug than a comparator. So that's interesting. And you can see it in this graph here too. So placebo is green, masitinib is blue, and you can see how nicely these curves separate. And this is, again, the graphs going up means that patients were getting worse. So the green was getting worse faster than the blue, right? And so again, the trial included 300 patients with either primary or secondary and non-active secondary progressive MS. That's important because all the drugs we looked at just now, they also looked at secondary progressive MS, but in their trial design, they looked at patients who were still having disease activity. They were progressing, but they still had either active MRIs or some relapses here and there. This trial specifically looked at patients who were not progressing. Okay, I'm sorry, who were not active, who were not showing active disease, but they were only progressing. So this is important and helpful. And these patients were, sicker. You can see the EDSS score, disability score is approaching 5.5. 6 means needing cane to walk. So again, I am cautiously optimistic and excited about this particular agent. So then a few other ones. Gosh, I can't even pronounce this one. Ublituximab. There we go. This is the one that's similar to a B-cell treatments that we've talked about. They're all slightly different in terms of how they're produced and how they bind to, how they deplete the B cells. But at the end of the day, this drug, if it goes through, will also be working on a B-cell system in the body, right? So it would affect that. The next one here, I believe also comes to us from oncology, because I know some patients in oncology clinics who receive these drugs. This is in a group of drugs called BTK inhibitors. Also inhibit B-cell activation, both in the lab as well as in clinical trials. Again, similar to ocrelizumab and ofatumumab, potentially in their biologic effect, ultimately on the body. And current trials are ongoing, phase 3, so late phase clinical development in relapsing and active secondary progressive patients against teriflunomide. And the simvastatin one is an interesting drug. You've probably heard about it because a few years ago it was in the news, showed some promise in progressive MS, still in clinical trials, and phase 3 clinical trials of high-dose simvastatin in secondary progressive MS is ongoing now. Okay, and really quick, phase 2. So these are earlier clinical development trials. We won't have time to go through every single one, but we'll just again see the mod. So this is another. One is going to join the group of the S1P receptor modulator treatments if it goes through. This one is interesting. It's a sodium channel blocker that's currently in phase 2 clinical development program. This drug is similar to some of the other sodium channel blockers that are used in epilepsy treatments, for example. And the hope for this one is neuroprotection. Early phase clinical development, so we don't have a whole lot to say about that, but still exciting. This drug here is one that's worked on by Teva. And it's also the idea is to block in a different way the same receptor that's blocked by natalizumab. So this one, if that works, this would be potentially similar to natalizumab, as is the next one, which is the oral treatment though. So it's an oral treatment that they're hoping to be similar to natalizumab. That would be exciting if that does work. And clemastine, you've heard about. This is an antihistamine treatment. Still in early phase clinical development. Actually, no, I think they did do a phase 3 now that's ongoing, but the phase 2 looked interesting in terms of effects. And then hormonal treatments, we've talked about it every time we've talked to you during McCourt Foundation events. Still ongoing research here, and then a few additional compounds here. Stem cell transplantation, on one hand, is an exciting development that's ongoing and trials are ongoing. On the other hand, there are some concerns, of course, about the safety and the efficacy of this therapy, especially in later stage multiple sclerosis patients. So I'm still cautious about this particular situation here. And I think this is all I have, so we can stay on target and on time, and I'm happy to answer any questions as we move into the Q&A session, if you have any. Thank you so much.
Thank you, Dr. Houchins. That was an excellent overview of the treatment landscape today and what we can expect in the pipeline here in the coming years. So we will, with that, move into the Q&A part of the session today. And so this is the part of the session where you really are guiding the topics and what we'll discuss for the remaining of the session. So there were questions that we've taken in advance and then and during the session here today. So joining Maria and I are two other panelists and longtime close friends, actually. First, I would like to introduce Nancy Sykott. Dr. Sykott is the chair of the neurology department at Cedars-Sinai Hospital in Los Angeles and is the director of the multiple sclerosis program there. And I've known Nancy probably since I was a baby neurologist, and she interviewed me for a multiple sclerosis National MS Society fellowship. One of the, I think, really excellent things about having Nancy join us today is that she's done a lot of work on a National MS Society task force related to COVID-19. So we're going to get a lot of her insight related to questions as it relates to COVID-19. And also joining us is my colleague, Dr. Farah Mateen. Dr. Mateen is the Associate Director of the MS unit at Mass General Hospital, and she's also the Director of Global Neurology in our department. So it's a great pleasure to have you join us. So with that, we'll move to our first question.
Question number one. Is there any information on COVID vaccine effects on MS patients who are not on immune response medications?
That's a great question. Nancy, do you want to tackle that one first?
Sure. First, I just want to say thank you to the McCourt Foundation for allowing me to participate today. And thank you, Eric, for making me realize how old I am. Either that or you're just a baby. So the question is there any evidence that the vaccines for COVID-19 would have bad effects in MS patients who are not on disease-modifying therapy? Did I get the question right? So let me just back up by saying that this has been an area of great interest to the MS community, and the National MS Society actually put together a task force to answer questions that we knew inevitably would arise as the vaccines became available. And in my role as the chair of the National Medical Advisory Committee for the National MS Society, we put together a group of individuals who have expertise in virology and in vaccines, as well as MS practitioners, to try and address some of these questions and give guidance, not guidelines, because we are really in a somewhat data-free world. And as Dr. Klauwater was showing, we're just starting to get some information about a brand new virus and how our patients are responding to it. So in terms of the vaccines, what we know so far, there are now 3 that have been approved or have been authorized for emergency use in the United States. And so we'll probably just be talking about those for this audience. And what we know so far is that they are very safe. And they are safe for people who have MS. They are safe for people who have MS, whether they are on a disease-modifying therapy or not. So the question has never been about safety and in terms of the relationship with disease-modifying therapies. I think we'll probably get into more nuanced conversation about the role of DMTs and timing of certain DMTs and vaccination. But I do want to start with our top line recommendation, which is if you have an opportunity to be vaccinated, take it. It doesn't matter which vaccine. And you should not be thinking about your medications in terms of being safe to have a vaccine. So when it's offered, get the vaccine. And that's been our top line recommendation. So there's no evidence to suggest that the vaccines cause any more problems in patients who have MS than the general population.
I'll add on to that, and I'll say, you know, in Boston, I have an awful lot of healthcare professionals that have MS that are patients of mine, and so I've already seen a great number of my patients get vaccinated, and I have not seen a single situation where the vaccine so far has caused any exacerbation of their underlying MS, or that side effects have been worse than what I've seen, you know, what have been expected to be seen based upon what we know from the clinical trials. So I think that is some added reassurance, certainly from my perspective. You know, when we think about vaccines and how they relate, we get most concerned with live vaccines. And so I think it should be emphasized, these are non-live vaccines. I think it was really fortunate that the first vaccines, and they were approved so quickly, had such good safety and efficacy, and were the types of vaccines that we could recommend so confidently to our patients.
Yeah, I would echo that. I think it's also a unique environment because we as healthcare providers were one of the first to be vaccinated. So we can actually give real world feedback to patients regarding what to expect in terms of the second dose side effects. And I think what we've been telling our patients is, you know, there may be some fever or myalgias, and you know, we do know sometimes this can bring out old MS symptoms a little bit more. So just to prepare people for that, and so they're not surprised. But I think our experience so far has been very reassuring in terms of the safety and how well people have tolerated the vaccine.
Yeah, in fact, I have my long clinic day typically on Tuesdays, and I got my vaccine on Monday, my second one on a Monday afternoon. And so I had a full day of clinic. And so when I was talking to my patients and they were asking, well, have you been vaccinated yet? And I was, yeah, actually yesterday, and I'm here with you and I'm doing fine. You know, a little muscle.
Well, you're a much braver man than I rescheduled mine. I have my long clinic day on Tuesdays as well, and mine was supposed to be on a Monday. I rescheduled mine to a Saturday and laid on the couch on Sunday. But you're younger than I am, obviously, Eric, so you tolerated it better.
I know we have other questions related to vaccines, so maybe we'll take another.
Next question is, what disease-modifying therapies are safe with the COVID vaccine?
So I think this is another variant of that question. So all of them are safe. There's no safety concerns with mixing the vaccine with any of the disease-modifying therapies. So I want to say that over and over again, they are safe to use in combination. The subtler point has to do with efficacy. And I think we saw that again from Dr. Klauwater's data showing that MS patients may not have persistence of antibodies after exposure to COVID. And it could be that that's a similar situation in people who are on disease-modifying therapies who are vaccinated. So that has to do with efficacy and has to do with the strength of the immune response, but not with the safety of the vaccines. And that includes the newest vaccine, which is the Johnson & Johnson vaccine, which is an adenovirus vector. And so some people may hear that and think that this is a live virus, which it is not. This is just it is a non-replicating virus. It's and it's a DNA vaccine, so it allows the DNA to get into the cells to create the spike protein so that an immune response can be mounted. So I think one of the really interesting questions and work that is ongoing and will need to continue, and I think Dr. Hutchins was talking about this in her studies, we really need to know how well our patients respond to the vaccines in terms of this immune response. But they are absolutely safe in combination. Again, we're lucky these are not live vaccines, and so we don't have those safety concerns.
That's
great. Yeah, go ahead.
Next question is, are the side effects from the COVID vaccine worse for MS patients?
I can jump in there, but I'd like to hear what other people have to say. So this is a bit anecdotal, but so far I would say no, we haven't seen that at all, that there's any significant difference in the immune response or the side effects from I shouldn't say immune response, side effects from the vaccine in our patients. I think there are differences potentially because of the number of shots that you get. So for the 2-shot regimen, we do see that the second shot does seem to have more symptoms. And that effect, from what I've seen, looks to be related to age, so that younger people actually tend to have a more pronounced effect for the second vaccine. And actually older people less so. And I have a brief anecdote. My 95-year-old mother had her vaccination, thankfully. And she told me very happily she had no response to either of them. She had no arm soreness, no fever, and she was very happy about that. But I'm also wondering if she actually had an immune response. But for the rest of you, any other anecdotes that you might have from your patients?
Sounds like good genes over there. So I agree with what was said. I think that of my patients with MS, and just like Dr. Clawwitter, we have a lot of healthcare workers and people who've already been vaccinated with MS in Massachusetts and surrounding states. And they haven't described symptoms any differently from the clinical trials or for any differently than people without MS. So I think overall, this has been very reassuring, and we're now in sort of the phase 2 in Massachusetts. So phase 1 and the beginning of phase 2 have been extremely reassuring.
I would echo that. I think I also, take care of healthcare workers with MS, and I haven't heard anybody complain. I think so it's about a 20% chance of systemic reaction, from mild to moderate after the first vaccination, regardless, I think, of Pfizer or Moderna. I don't know what that is for J&J yet, actually. And about a 40% chance for some kind of systemic reaction after the second one. And I don't think that MS patients are any higher risk or lower risk necessarily for the systemic response. So I also don't know whether, to Nancy's point, whether having had that response would in any way inform us about immunity production, right? So some people say, oh, I felt terrible, I'm probably immune. Well, maybe, maybe not. We don't really know that. We don't know what we're reacting to exactly when we do develop a systemic response. So I wouldn't be disappointed if you don't happen to have a response, but I also wouldn't be super excited if you did have one in terms of, whether or not you're now immune to COVID. But the good thing is we can now check for COVID immunity. There's a test, right? So, and that's exciting, very exciting for me personally, because I can now test all my healthcare workers who are vaccinated on various MS treatments and tell them, yes, you're immune, probably. No, you might not be, probably. So it's better than what we could do even 2-3 weeks ago.
I would add that I was just like Nancy. I think I spent the day after the second dose more on my couch than not. So I don't know if I would have been able to pull off a clinic like Eric did. So impressive, Eric.
The next question is, when should patients on Ocrevus receive the COVID vaccine? And should infusions be delayed in coordination with receiving both doses of the vaccine?
I think this is the area of controversy, I think, right now. So I think we probably have differing opinions, maybe even on this panel. I think a lot of the recommendations, and including in this case, they're based on theory, right? But Nancy, why don't you start us off, since I know your task force has spent considerable time discussing.
Yes, this is sort of the crux of the issue. So as we talked about, most of the DMTs don't have an impact. We don't recommend doing anything in particular. If you're on them, just get the vaccine when you can. The only caveat would be just theoretically thinking about the B-cell depleters. So these are the infusion therapies and now injectable therapy that deplete B cells. And B cells are, of course, responsible for responding to vaccines and generating what we think is the most important response, which is the humoral response and neutralizing antibodies. So the truth is, we don't have data, significant data at all for the COVID vaccine. So we have to rely a little bit on other data from other vaccine studies. And there was recently a study published called the Veloci study that looked at immune responses 12 weeks after induction with ocrelizumab. And that demonstrated that there was an immune response, but it was somewhat abrogated in those who had received infusion with the B-cell depleting therapy. So it's about a third as robust. So what we can learn from that is that immune responses can be generated even in the setting of zero circulating B cells, as we detect with our CD19 counts. So that's encouraging. But it does also tell us that the immune response may not be equivalent. The other caveat I would say about that data is that some of those, the vaccines used were flu vaccines, and those are recall antigens, because most of us have been exposed to previous flu vaccines. So it's not exactly the same as a novel antigen that we're seeing now with the COVID vaccines. So I think we have to be a little bit careful about extrapolating that data. Now, that said, our group feels very strongly that individuals should not be discontinuing their disease-modifying therapies in order to get their vaccination. We very strongly feel that this is not the right approach. There can be some opportunities to time the vaccine with infusion. And I think again, the take home for the group would be really on the back end. So after you've been vaccinated, waiting at least 2 to 4 weeks after that second vaccine before you do your next infusion, if you're doing the B-cell depleter by IV or your injection. And that's in order to let the immune response be generated maximally before you initiate therapy. So that would be my first take, but I'm very interested to hear what other people think and how they're sorting through this.
So there are a couple different scenarios, I think, in this case. And what Nancy was just saying was that if you're about to start one of these treatments, that really it's the ideal time to get vaccinated then, before you either switch to that therapy or if that's the first treatment that you're starting for MS. So I would really emphasize that that's the case, or that's important. And then there's also, when you've been on ocrelizumab, as an example, for a period of time, and now you're eligible for the vaccine, but you had your last infusion, let's say 2 months ago. I think the question is, well, should you get vaccinated now, or should you wait then until the end of that 6-month cycle? And it's possible that you might develop more of an immune response if you waited. But what I guess the question that I, when I'm counseling patients in that situation, what happens over the course of that 4-month period of time, right? Should you get vaccinated now, and then potentially have some protection over that period of time? And so I've taken the standpoint that you should get vaccinated when it's available to you, whether you're on Ocrevus and you're in the beginning part of that 6-month cycle, or at the end, or on another treatment. And that's based upon trying to give the greatest potential for developing some immunity in the short term, while case counts are still high and people are susceptible. But I think there probably are varying opinions, and it also can depend on from one situation to another, I think, in my experience.
So I can play devil's advocate here a little bit. And it's I love doing that. But and it's not that one approach, as Dr. Clowder pointed out, it's not that one approach is correct and the other one is not. I think we just don't know yet, and that's true. That's the truth, right? We don't have the data to be able to share with you to say that yes, this is definitely the right course of action. So in my clinic, I recommend actually waiting as long as you can. So let's say you were treated, as Eric said, 2 months ago, right? And you're eligible to get vaccinated. I would actually wait additional, few months before getting vaccinated to get as close to the end of that time, from the cycle of the 6-month cycle between the infusions, as close to the end of that, as close to your next possible future infusion before you get vaccinated, because the alternative situation is, let's say you get vaccinated in 2 months after your previous treatment or 3 months after it. We don't know how robust your immune response is. Let's assume the worst. Let's assume it's not robust at all, or you can't develop it, right? Because you've been immunosuppressed with the B cells not detectable in your bloodstream. You would then be assuming that you're protected, whereas you're actually not. And then you're going to be out and about and sort of feeling good about it. And then your chances of getting sicker, or sick, not sicker, but sick with COVID, probably higher under those circumstances, right? Whereas if you know that you need to be careful for another few months, and then there is probably going to be a higher chance for you to develop immunity to the vaccination, considering that we can't re-immunize people. We don't have enough vaccine to go around as it is, right? So we can't, if we check and you're not immune, you can't necessarily receive a 3rd dose or a 4th dose. Plus, we don't know whether it would even work or whether it's safe or not at this point to get them so close together, right? So I recommend waiting, getting vaccinated, and then waiting, as Nancy said, another month after your last vaccination, shot number 2, and then receiving your treatment. So that would delay your next infusion by probably 2 months, maybe 3 months at the most, which for most patients is okay. There's an occasional patient who is really active and had really active disease from the onset and were put on these treatments because they had really active disease. For those patients, it's much more challenging because it's probably not okay to delay the infusion or the injection. And that's why you need to be in touch with your neurologist to really discuss your specific, issues directly.
And I guess just a few additional thoughts. That was a great summary by the others, but I think this is exactly where personalized MS care is the most critical. And so in these, as you heard, some data-free zones here where each individual case and the risk of being even temporarily delaying a DMT could be considerable. So what I'm telling my patients right now, and this is partly related to the world we're in and the logistics of vaccines and testing and data, I am telling folks to get vaccinated when they can and not to wait right now. Another consideration I have is that, maybe people are immunosuppressed throughout the 6 months of their ocrelizumab or their rituximab or whatever B-cell therapy they're on. And so even though theoretically at month 5.5, you're a little bit less immunosuppressed than the week after your dose, maybe you're still really immunosuppressed even up until your next dose of ocrelizumab or rituximab, et cetera. So I often think, well, even if you wait 12 weeks or longer, maybe that's not actually enough waiting. So I think the jury's out here. I think these guidelines are like kind of a living document. And as we learn more, I think we're in constant communication with folks about every little step further that we're along on the knowledge pathway, but sometimes it's hard to give a great answer. And that's where I think you get controversy and sometimes different opinions among experts. But in general, I think the safety is clear. I think we're just trying to figure out how good is the vaccine in folks.
So Farah, I want to thank you for that, because I think that really summarized it well. And I think that the key points here are context. And the other piece that I would say is part of it depends on the risk profile for the individual. And I think Maria was alluding to this, but if you have patients who are frontline workers who need to go out and are going to be exposed. And if your current situation is one of high transmission, this it maybe will affect your decision making rather than someone who has the opportunity to stay at home and be isolated and can wait. So I think the context is really important. I think taking into account your individual patient and their experience and where they are in their disease is really important too. And this is really something that requires a discussion with your neurologist. And then the final thing I'll say is what we have, the living document is living. We're about to put some more modifications to it. And we're calling this guidance and not guidelines because, as you alluded to, the data is limited. So we're trying to move as we develop more information. Thanks.
That's great. I'm going to put on my Anthony Fauci hat on again and say, in this case, here's a video of my face planted on Anthony Fauci in front of a podium where I'm saying, even if you've been vaccinated, you still need to be careful over the next couple months.
That's beautiful, Eric. Beautiful.
That's a deep fake. That's pretty cool.
Okay,
You
on
made,
that
you
scary
made him
note,
look,
the
you
next
made
question
Tony
is,
Fauci look so young.
is MS considered a comorbidity to receive the COVID vaccine?
I'm happy to start with that. It's very complicated. The short answer is the CDC has not identified MS as one of the comorbid conditions that would allow you to move up to the 1C, I think it is, tier. However, just to complicate things, every state is able to generate their own priority list. And they could, and I actually don't know this right now, if there are states that have included MS within that category. Sometimes you could be included if they're talking about immunosuppressed or people who are immunosuppressed. Some places say from cancer treatments, and so they put that qualifier on it. So it is a very confusing environment and differs state to state. So I'll just say that two more things. California right now does not have MS as one of those health conditions, and that also the National MS Society has been lobbying the CDC to include this as one of those conditions. And there were many, many other organizations that were doing the same. And it turned out they had to do a lottery before, and the MS Society was not chosen. They submitted a letter instead, and I co-signed that letter in my role as the NMAC chair. But so they've been trying to lobby the CDC to get it moved up. But I don't know what the situation is in Massachusetts.
It's exactly the same. It's the Massachusetts is using the list of conditions that put people at increased risk, and I guess technically you could consider MS and being on immunosuppression as on the list that they use as might is what the CDC has used. Now, that could always change, right? Any given state could decide that they, as part of perhaps the next phase, they want to prioritize, instead of opening up to everyone, they may say, okay, well, this second group of conditions we may prioritize here initially. So it, I think, to be determined, but as of right now, it isn't included in Massachusetts either.
I've heard a number of politicians speak about the goal to get as many Americans as who wish to be vaccinated by the end of May vaccinated. So I think the pace of vaccination is going to pick up fairly rapidly in the next few weeks. And definitely by the end of spring, the hope is that no matter what, that you will have access to the vaccine. Some of my patients have also looked at other things that are technically comorbidities that may not be listed on their chart. For example, asthma or their BMI, and those might actually qualify that person for a vaccine, even though their MS doesn't. So some people have sort of read the fine print and found that they're eligible, but not because of their MS, in fact.
Next question. Can you please discuss Ocrevus infusions and the side effects on the body?
Maria, do you want to go ahead and grab that one?
Yes, I'm trying to find my mute button here. Yes. So ocrelizumab, it's a very good question. So the product itself, the monoclonal antibody, in terms of side effects, as I'm sure you know, the immediate side effects are not particularly concerning. That could include infusion site reactions, excuse me, infusion reaction, not infusion site reactions, in a form of just an allergic response to the infusion as you're receiving it or shortly thereafter, right? So redness, fever, tingling in the back of your throat. We're quite good at this point managing those during the infusion treatments. Longer term effects primarily include increased risk of infections. And from that perspective, the longer somebody stays on ocrelizumab or rituximab for that matter, probably has some correlation as to the frequency and possibly severity of infections. In my experience, and again, this is something you would not necessarily see in clinical trials because they're time limited. So clinical trials are run for 2, maybe 3 years if you're lucky, and then they stop, right? So what we see in clinical practice might mirror that, but only again for the duration, for the equivalent duration of treatment. If you go beyond the time that the drug was used in clinical trials, you don't know necessarily what to expect. And that's why it's important to report side effects as patients and experience them and as doctors see them in their patients. So again, the risk of infections, what I've seen in my clinical practice is after 2 to 3 to 4 years on these types of therapies, there seems to be an increasing frequency in my patients of especially upper respiratory infections and sinus infections in particular. And those sinus infections can be really hard to clear. And they sometimes end up being, patients end up needing multiple courses of antibiotics and, multiple visits to an ear, nose, and throat specialists and so on and so forth. Somehow I see that more than I see bladder infections. There's also correlation between the decreased IgG levels in patients on chronic B-cell suppressant treatments and infections. So as we treat our patients, we oftentimes check their immunoglobulins, the IgGs, prior to infusions. And if we see that they're dropping over time to concerning levels, and especially if at the same time the patient is developing multiple infections that are hard to clear, then that potentially becomes a concern. If you look at the drug label, there's also something there about malignancies, high risk of malignancies, particularly with ocrelizumab in clinical trials. There was a question that was raised about possibly higher risk of breast cancers in the trial. So they saw, I believe, 8 cases of breast cancer in the treatment group and none in the control group. It's a very common cancer. It was a little bit strange as to how this kind of aggregated, more in one group than the other. But upon reviewing all the data, FDA did not recommend any additional screening for patients, no breast MRIs, no increased frequency of mammograms, and so on and so forth. They are not seeing that in real world use of ocrelizumab. So I don't believe that there is an increase in breast cancer that the company has reported sort of post-approval of the drug. Having said that, if I have a patient with a personal history of breast cancer, even in remote past, or very strong family history, or perhaps a BRCA1 or 2 gene carriers, I would probably not use this drug. If you asked me to give you a good explanation for that, I might not be able to, but there is just a sense that because of that little signal that they saw in trials, I'm just, under those circumstances, I would be cautious. But in general, I don't believe that this is a big significant risk. In terms of other malignancies, again, there's a hypothetical risk with prolonged immunosuppression, regardless of the type of immunosuppression, of increased malignancy in the future. And I think that risk is probably real. I haven't seen it actualized with ocrelizumab because it's only been on the market for 3 years. I would imagine that this would be a multiple years of exposure. I don't know how many years, but certainly more than 3 years. We haven't seen anything or heard anything presented or reported by the company or by colleagues of ours that would raise that kind of concern now. But could this become a concern 10 years from now? Possibly. So that would be my response.
Next question. What are your thoughts on keeping patients on disease-modifying therapies that chronically suppress the immune system?
Yeah, I think Maria was just talking about that. I think there certainly are, we have concerns, and as she talked about, some of the side effects can be greater as you're on an immunosuppressant longer, for instance, related to the immunoglobulin levels decreasing. That can happen as you're on the medication longer, and so risk of infection. So that's why we monitor. I guess I would say that's why we monitor those levels periodically, so that if there are recurrent infections, we can recognize why that's the case, and potentially even institute additional treatments like giving intravenous immunoglobulins that can help prevent.
And I would just add that this is something that everybody's paying attention to. So it's really at the top of mind for a lot of neurologists, as well as patients and people with MS. And the other thing I would mention is that there are other disease states that use long-term immunosuppression, and we can borrow some of their data. For example, rituximab and some of the other medications we have are either kind of borrowed from other disease states, from autoimmune conditions, or we can at least borrow their safety registries. And some of those diseases are actually more common than MS, or have had their drugs around longer. So a lot of that data is also reassuring. So some of our thoughts on this are more theoretical than proven. So it's good to be thinking about it. But right now, there's not any major stop point for some of these drugs. So we're continuing fairly favorably right now.
So the only other thing I would add is just thinking about regular health maintenance in these individuals. And so as part of our annual evaluation, make sure that people are seeing dermatologists, in particular here on the West Coast, annually, because skin cancer is the most common cancer and has been associated with exposure to immune suppressing medications, mammograms, colonoscopies. So we act like primary care physicians in many ways, but this is part and parcel of managing people who are on long-term immune suppressing medications.
Well, it looks like Maria and Eric are both outside right now.
Are there myelin restoring drugs in the pipeline? And if so, when might they be available?
Well, Maria touched on one of them, clemastine, which is in a phase 3 clinical trial at the University of California, San Francisco. And so that showed some promising data, as she mentioned, in phase 2. We at MGH are a site for another remyelinating drug called elezanumab, and that is just finishing phase 2. So we should get results from that in the next couple months. I'll say 2 years ago, as part of the McCourt Foundation educational update, I gave a short 15-minute talk on remyelinating drugs and sort of what do we know about the biology that's really informed the development of these treatments, and what's the potential for the future. So if you can find that on YouTube someplace, there's another reference.
In relation to that, will remyelination therapies help with people with EDSS greater than 5?
We would love for that to be the case, and I think the answer is we don't know how a potential response, if it will be variable across duration of the disease and in various disability levels. But fundamentally, the real potential of remyelinating drugs is that they could help improve disability level. And so we may find that some drugs are most potent in certain populations, but ultimately we're going to keep working until we find and develop treatments that work across the entire spectrum of MS, including progressive MS.
Does a low inflammatory diet and consistent exercise help to slow the progression of MS?
So I can take that one. So those are big questions. Some of the most common questions I get in clinic are around the things that we have less data on, so diet and exercise. In general, a good diet and regular exercise are good for you. So I'm not of the opinion that there's a specific MS diet that will alter your disease course. So I always tell folks that it's important to take your disease modifying therapy. That's the major impact you can have on your disease course. And that there are other things that we understand, like vitamin D supplementation is important, but overall, I don't recommend any one specific diet. I don't think we have the evidence to suggest that that will alter your disease course. What I also tell folks is that there's some things people want to try. I would just be cautious that it's not expensive, that you don't spend your personal money on it to the extent that that is compromising. And also, if you want to try something, just to have a discussion with your physician about that and make sure there's nothing about it that sounds potentially unfavorable. Exercise is obviously a big category of things you can do, and there are all sorts of exercises that people do on a regular basis. In general, maintaining good cardiovascular health is shown to be very important in terms of brain health longer term. There's all sorts of things in terms of balance and coordination that have been helpful for people with MS. But in general, in terms of altering the disease course of MS, it's still mostly immunosuppression. I think that's really our major weapon against the disease right now.
Maria, I know at Brigham and Women's Hospital, you've done a fair amount of work with the microbiome and how diet might modify that. Do you have thoughts related to that impact of diet on the immune system?
So you're right. So Dr. Howard Weiner and some of our faculty and fellows have been very involved in the microbiome work. I think that a bird's eye view of this is that our guts contain, tremendous number of different microbiota. And what we've learned over the years is that in people with autoimmune illnesses, MS and others, even in a setting of not being on treatment for those illnesses, the microbiota appears to be different from those patients who do not have autoimmune illnesses. And MS is one example of that. We are currently, or my colleagues rather, currently looking into how can this knowledge help us, how can this knowledge migrate from laboratory to the actual patient treatment paradigms? I don't think we're there yet. There's certainly a lot of work going into looking at different diets that would be healthy and good for you, in terms of cardiovascular health, in terms of something as Farah pointed out, are considered the low inflammatory diets, potentially, or gluten-free or dairy-free or whatever you want to think about. How would that translate into the actual changes in the gut microbiome system, as well as in the actual changes that we can quantify in our patients? And this is an ongoing research for sure. A lot of interest in that research. But I don't think we're quite at a point of being able to tell you today, when you go to your dinner table tonight, please eat this and don't eat that. I don't think we're quite there yet. But excellent questions, though.
So I'll just chime in here. Again, interested to hear Farah say that's the most common question she gets, because I will say that the question I get most often after making a diagnosis of MS is, what is the diet that I should be on? And patients are actually very disappointed that we don't have a particular diet to prescribe to them. But how I try and frame it is, we do have good data that anything that is good for your blood vessels in the long term is going to be good for you and your brain and for your MS. And we see this in aging and other comorbidities in our patients, that those are associated with worse outcomes in the long term. So the recommendations we give are mainly the Mediterranean diet, since that has the best data and is a healthy, enjoyable diet. I also let people know that eating is, we're talking about quality of life for patients. They're going to be living with MS for many, many years. And eating is one of life's pleasures. And If we had good data that showed you had to eat only one food forever and it would cure your MS, maybe we would prescribe that, but we don't. So in the absence of that, people should eat a good, healthy diet. And then the other thing we talk a lot about is exercise, because I think exercise is the miracle drug. It helps with mood, it helps sleep quality, it improves inflammatory state. Makes you cardiovascularly fitter and improves your long-term outcomes. It's good for cognition. So I think that this is, again, part and parcel of the prescription for MS patients that they need to get out and really get their heart rate up. So aerobic exercise in particular is shown to increase the size of gray matter structures in the brain and help maintain that. So, so that's also what we're recommending here.
Yeah, my very first treatment for fatigue is aerobic exercise early in the day, in the morning.
Which certainly the patients say, why, what are you talking about? I'm too tired to exercise. And it's sort of this vicious cycle. That and sleep quality. So that's another really important kind of basic thing. A lot of our patients have very poor sleep from various problems with restless legs and getting up to urinate in the middle of the night and so forth. So that's the other big question when someone's fatigued is, what does your sleep quality look like? And having screens on in your room and during the pandemic, I think a lot of it has worsened overall as well.
Okay, we have 4 questions left and we have a maximum of about 7 or 8 minutes. So our next question is there a medication to assist with the regulating body temperature, particularly sensitivity to heat?
I can take that, and I would say probably not. That would be an easy answer. There's a commonly used medication that was found to be helpful in postmenopausal women in terms of nighttime sweating and hot flashes, and that's medication that many of our patients are taking already today, and that's Neurontin or gabapentin. So that's worth a try. But specific medication that would help with specific body temperature regulation in MS patient population does not exist.
For people that do have a lot of heat sensitivity, one of the things that I recommend is on hot days, always having a bottle of ice water that you're constantly pumping cold fluids into your body, and then also the cooling vest can be an effective option. And
yeah, there's also those wristbands where you can have kind of the ice around your wrists. So.
Can CBD oil be taken to manage pain?
The answer is yes. It can be taken to manage pain in states where it can be legally prescribed, which I think are many, many states in this country. It can be quite effective. In fact, I've had patients who were able to stop some of their prescription medications once they started taking that. I would be careful though, and I would specifically really try to focus on the relative concentration of CBD versus THC in any especially in a preparation that people take orally. There's usually a little bit of THC present, and that's okay. But if there is a 50-50, or if there is a significant proportion of THC in the oral agents, you might find that the cognitive function, could be a little bit affected by that. But in general, yes, CBD oils can be used and can be effective.
The remaining 2 questions are in relation to diagnosis. When do you consider reevaluating an MS diagnosis and consider NMO? How often do you then test for NMO antibodies?
Sorry, I was muted there. I was saying this is the lightning round now. I like it.
So I'm sorry, Vera. I was going to take the misdiagnosis question because we've done some work on that, and also we're just starting the CAVS MS study to look at new imaging biomarkers to help us differentiate MS from non-MS early in the course. So in terms of when do you reevaluate, I think every time you see your patient, you should be thinking about revisiting their diagnosis. Because there certainly is a high incidence of misdiagnosis, and work that Marwa Casey did here at Cedars, she found almost 20% of patients referred to us and over at UCLA with a diagnosis of MS turned out not to have it. So I think it's important to keep that in mind. And then since this is a lightning round, just some red flags would be severe optic neuritis that doesn't recover well, certainly bilateral optic neuritis, and then longitudinally extensive transverse myelitis. These are all signs that would point toward either aquaporin 4 or MOG disease. And then intractable hiccups and vomiting is another real red flag for thinking about alternative diagnoses. And I don't know if and sorry, Farah, I interrupted you.
No, it's the lightning round. So, just for NMO, there is a biomarker, which is a blood test. And if there's a high suspicion of NMO, that's usually checked twice, 6 months apart. But I agree. I think every visit with a neurologist is sort of keeping your thinking cap on, making sure there aren't any red flags like you just heard. And, there are biomarkers for some of the mimicking diagnoses. And so that can be helpful. But it's really just it's a evolution over time, but generally the criteria are pretty clear. So I think we're getting better and better at making the diagnosis with time.
And the final question, how do you tell the difference when speech problems arise? That is it MS flare or a stroke? If speech problem causes difficulty in forming words, swallowing, chewing, and drooling, and his first time ever happened, is it flare or stroke?
So I'm not sure, of course, who asked the question, but I recently had a patient who suffered a small stroke, quote unquote, and also has long-standing MS. It is difficult sometimes to tell because our patients with MS might also have trouble with speech production and articulation, not so much comprehension. So I think it would really have to be a good neurological exam so we understand specifically what that speech difficulty is exactly. Is it saying, producing words, or is it thinking of words, or is it understanding words, right? So strokes can do all of the above. With stroke, typically, if speech is affected, it can be quite severe if a stroke is large, but it can also be very, very subtle. If a stroke is small, it just happens to be in the right part of the brain tissue. With multiple sclerosis, it's very unusual to have a relapse that would specifically affect speech production. Typically what we see is over time, articulation gets a little bit impaired, can get a little bit impaired in our patients. So it tends to be more of a kind of a chronic, maybe a slightly worsening over time process rather than acute, I woke up and I can't speak situation. So that could help distinguish between the two. But fundamentally, even in this virtual world we live in now, I think a good exam from a neurologist who understands speech difficulties is really important and would probably help distinguish between the two conditions.
And Eric, just before we have you wrap everything up, I would just like to encourage everyone to visit our virtual event booth where you can directly interact with biopharma representatives via video chat, as well as learn more about therapeutic offerings and clinical trials. And the link is below this video. Final thoughts, Eric, thank you.
Thank you, John. Well, this was a real pleasure to be with all of you today, and hopefully some of you that may be watching this some days after as well, as that's posted on various social media platforms. I want to thank all of our speakers and panelists today. It was a real pleasure to join you this afternoon. And then, of course, a great thank to the McCourt Foundation for all that they do for our patient populations throughout the country, but specifically now in the bi-coastal Boston and LA area.
The day I found out I had a progressive like sensory event where basically my hand and foot, I woke up and it was just pins and needles. And because I was about to finish school, I could diagnose these things, and I had a really strong understanding of like the neuromusculoskeletal system. And so pins and needles is pretty much nerve, almost always. And so I was like, well, that's not great. But kind of ignored it, and it progressed to the entire left side of my body. And that's when I went to the hospital. They said they wanted to get an MRI, and as I'm being loaded into an MRI, for whatever reason, he's like, yeah, we're running a scan for MS. And, you know, they shove me in the tube and you're totally still and you've got a cage over your face. And in my head, I was like, I started like doing the math, and I was like, this is not good. Like, I have MS. Like, I just knew at that moment. And, you know, I don't think it really hit me the next day until I had to tell my mom. And my mom's a nurse. She's very well educated, and, you know, having to like sit her down, I think she took it much harder than I did. And then I was just really angry. I was, you know, I was pissed. Through the McCourt Foundation, I think it's the understanding that that this organization is completely selfless. I think hope is really important for people, and there's the opportunity that like one day maybe I'm cured of this, you know what I mean? And I tell the story like this one time I had MS versus I have MS and will always have MS.
I'm a neurologist at the Massachusetts General Hospital, and I specialize in multiple sclerosis. And I've been at MGH now for just a little over 10 years. So my research focuses on a couple different areas. One is related to clinical trials. So looking at new therapeutics in multiple sclerosis. I also have a research lab that is devoted to imaging, so looking at new ways to assess multiple sclerosis, ultimately to come up with biomarkers that we can use in those clinical trials. I saw that there were some big opportunities to improve our treatment of the disease. And MS is also unique in the sense that most people are diagnosed at a relatively young age, in their 20s or 30s, a time when they're really in the productive years of their life. And I felt like this was really a condition that, as a physician, I felt like I could really make an impact on people's lives. Partnering with the McCourt Foundation now for, I think, more than 5 years. And I think it's been really valuable to making an impact on our ability to treat people with neurologic disease. And so myself as an MS specialist, I can tell you that really some of the most valuable partnerships allow us flexibility in really focusing research funds where they're needed most. And so I think that there's a big advantage of being able to say, here is an immediate need or an immediate question that needs to be answered, and to be able to do that as quickly as possible. So that's just one example of how this partnership with the McCourt Foundation has been just really valuable and allowed us to make impacts immediately.
dad, I'm an only child. I grew up in the house that my dad grew up in. And he's just, I know I'm biased, but he's one of those really special people who touch a lot of lives. And I've really realized that since, he was a police officer in the town that I grew up in. He would just, throw off his gun belt, play basketball with kids. He just was an inspiration and still is. And his positive outlook on life, I try to kind of channel when I'm having a tough day. So always went the extra mile to help people. He's inspiring to me because he was always so positive and had the strongest kind of mental ability of anyone. Like, he could push himself through anything. And he inspired me as a child in many things, but running was one of them. He got me into it. He ran a bunch of Boston marathons, and I grew up on the route, so I got to watch him. Looking back, there were probably some signs, but he got it. He was diagnosed with early onset dementia. They called it semantic dementia, so it's a loss of words initially, and then it kind of flows more into Alzheimer's. He started to kind of describe around things, and that's when we kind of, he wouldn't be able to think of a word like sweater or something like that, and he'd say, the thing you wear to keep you warm. Receiving the diagnosis, though, was really hard. They first diagnosed it as depression, and we were like, he's the least depressed person we know, but I think it was probably in his head, it was tough because he didn't know what was happening to him. Again, I always wanted to run the marathon with my dad, but that didn't happen. And I was fortunate enough to find McCourt Foundation, who had a team, invited me on. I raised more money than I ever thought I could raise. I raised $19,000 that year. And the way their family is so invested in helping, and it was amazing. And I look back and I think, even though the weather was terrible the year I ran, it was one of the best experiences of my life, and one of those big bucket list goals that I always had. And I knew my dad would be so proud. He definitely helped me get through those latter miles of heartbreak and holding down stuff.
The Department of Neurology is part of Cedars-Sinai Medical Center, and we think of ourselves as neurosciences, so that includes both our neurosurgical partners as well as our neurologists. We work together. So we have world-class neuroscientists who are using an opportunity that we get from epilepsy surgery to really understand fundamental ways that the brain works, and in particular forms memories. And as you know, this is a key area for dementias, for Alzheimer's disease. And so we're doing work with patients who are undergoing depth electrode placement for possible surgical resection. And so they're having recordings done. And while they're sitting on the ward waiting to have seizures that are informative and help with their surgical planning, they're also doing experiments, and they're having recordings done. Fundraising is so important. I think about it as like the rocket fuel that gets things going. It allows you to do things that are maybe a little bit riskier, but also have the biggest payoff. So when we're trying to really do unique, kind of new and risky things, having philanthropy allows us to really do that crazy experiment, take that risk. So in those early years, it's really critical that we have access to funds so that we can really support these really exciting people. And so if we can really raise the level of care that people are receiving and raise access throughout the Los Angeles area, it's really the goal of Cedars as a medical center, and make all of the cutting edge therapies that we're working on available to the widest number of people across Los Angeles. So that's the thing that gets me really excited when I'm thinking about what we're working toward, because we have this opportunity to really sort of raise the standard of care, not just for the people who are here at our medical center, but throughout the whole Los Angeles area.
I'm Brian McCourt, president of the McCourt Foundation, and we'd like to welcome you all here today for the first ever virtual McCourt Foundation educational update. We've got a fantastic lineup of physicians that will be presenting today. Physicians that are not only top in the country, but top in the world in their respective disciplines. We're excited about having you all here and hosting you, and would also like to thank all of our sponsors that are making this possible. But I'd like to especially thank our presenting sponsors, Bristol Myers Squibb and UBS Financial, as well as our silver sponsor, Sanofi Genzyme. But I would like to thank all of you for being a part of this day. This has always been one of our favorite and most impactful programs, and it's all because of you. So enjoy the program. I'd like to now introduce Steven Sypek with UBS Financial.
Thank you, Brian. And thank you for joining us today, and welcome to the McCourt Foundation Educational Symposium. My name is Steve Sypek, a financial advisor with UBS Financial Services here in Rockland, Massachusetts. I've been friends with the McCourt family for many years and personally involved with the foundation for over 20 years. I too have been impacted by neurological disease, and that my mother passed away from Parkinson's 5 years ago this year. I am excited for today that you will be hearing from the top doctors and researchers from Massachusetts General Hospital, Brigham and Women's Hospital, and Cedars-Sinai Medical Center on their progress and developments in the areas of multiple sclerosis, Alzheimer's, and ALS research. We all know the challenge that individuals and their families face in dealing with neurological diseases. And that is why I believe the McCourt Foundation focus on making things better by supporting research, providing education, and developing strategic health-focused partnerships will one day lead to a cure for many of these diseases. As a financial advisor, I know the challenges that these patients and their families face in planning for the unexpected and in dealing with the emotional, physical, and financial challenges. We believe that the financial services industry can help families plan for those unexpected circumstances, and also help support the critical research and awareness in the areas of neurological diseases. And that is why UBS is excited and proud to support the McCourt Foundation in their great work and their mission by sponsoring today's educational update. Thank you for joining us. I hope you find these sessions helpful and that they will continue to inspire and empower you and your loved ones in making things better each and every day. Enjoy the upcoming update.
I'm James Berry. I'm standing in for Merit Zakovich, who sent her regrets and isn't able to be with us today. I'd like to welcome everybody back from the break. I know this has been an exciting day so far. Thank you all for joining us this afternoon. We're looking forward to another exciting session. We'll be talking about ALS and ALS research. In particular, I'd like to thank, before we get started, the McCourt Foundation. We're grateful to have the opportunity to come together as a community today to talk as a whole group. The remaining time today will flow as follows. I'm here with two really incredible colleagues of mine from Mass General Hospital, Drs. Ghazaleh Sadri-Vakili and Suma Babu. Each of us will be giving a brief presentation highlighting exciting updates about ALS and ALS research, many of which have been made possible through the support of philanthropic partners such as the McCourt Foundation. Our presentations will be followed by a question and answer session. Now, I'm going to speak first, and again, my name is James Berry. I'm the Winthrop Family Scholar in ALS Sciences and Chief of the Division of ALS and Motor Neuron Diseases at Mass General Hospital. Today, I'll talk about the Healy ALS Platform Trial and Expanded Access Program, and how we can reimagine and accelerate the discovery of new therapies for people with ALS. Now, before I dive into the platform trial, just a few words about amyotrophic lateral sclerosis. This is a neurodegenerative disease. It's primarily characterized by its effect on upper and lower motor neurons, upper motor neurons residing in the brain, lower motor neurons in the spinal cord. Classically, this is described as a painless progressive weakness, although that belies the truth of the illness in more progressed states at some point. It's characterized by an asymmetric onset and a regional spread. In other words, it often starts in one limb and can spread through that limb into an adjacent limb before spreading to other parts of the body. It may also start in or around the mouth in what we refer to as the bulbar region. The disease spares eye movements and bowel and bladder function until very late in the disease if they are affected at all, but they can be affected. The average survival after symptom onset is 3 to 5 years, but there's a very wide variability, and there are some people who survive more than a decade and even long beyond that. The average time from symptom onset to diagnosis is 12 to 14 months, which is a difficult reality of the diagnostic process and something that Dr. Babu will talk about later. A longer delay actually correlates with slower progression later in the disease. About 10% of ALS is what we call familial or caused by a mutation in a single gene, but we found these causative mutations in over 30 to 50 genes. 90% of ALS is what we call sporadic. In other words, we don't have a genetic cause of it, a single genetic cause of it anyway. And the last and really important point is that there is a blossoming research and clinical trial landscape in ALS. Now, we think of ALS as an uncommon disease. Some people call it a rare disease, but the reality is that it affects 1 in 300 men and 1 in 400 women throughout their life. And that incidence is increasing globally, in large part because it's more common in older people. We see about 5,000 new diagnoses of ALS every year in the United States, and there are about 20 to even some estimates are 30,000 people living with ALS in the US. The average age of onset is 55, and there are 4 FDA-approved treatments. Now, it's important, I think, to look at the timing of those FDA-approved treatments because we are making headway, and we're making headway at a faster and faster clip. So in 1995, riluzole was approved to slow ALS progression, the first disease-modifying therapy. In 2010, Nudexta was approved to treat pseudobulbar affect for ALS, sort of an abnormal laughing or crying that can come with the disease, and was very difficult to treat prior to that. In 2017, edaravone was approved to slow ALS progression. In 2018, liquid riluzole was approved. And in 2020, we saw very exciting positive results from a trial of a drug still referred to by the name AMX0035. And Dr. Babu will talk, I think, a little bit about that later. Now, ALS also has a robust therapeutic pipeline and pressure to move fast. The NEALS Consortium is a group of research sites of over 100 sites throughout the US, and it connects us and binds us together in a mission to find cures for ALS. There are over 160 companies that are working in the ALS space, each with at least one drug, and thousands of investigators worldwide working to find new targets in ALS. At the same time, people with ALS say, like Sandy did, I lost the privilege of working on the human time clock when I was diagnosed. The ALS time clock is a lot faster, and we appreciate that and work with that in the front of our minds. The best way to make progress in this situation is to test therapies efficiently, quickly, to find the ones that work. And to that end, we've designed the Healy ALS platform trial to really bring together an entire community to rethink the ALS trial landscape so that we can do this faster. Now, when we had this kind of concept, and really it was Dr. Sokovich who really set the stage for this platform trial and has led it. And really the idea was to bring together investigators, industry, FDA as regulators, clinical sites, and put at the center of all of that people with ALS so that we could move rapidly from the concept of this to launch. And we did that much faster than there are platform trials in a few other diseases. Those took years and years to design and launch. We did that in about 12 to 18 months. To explain what a platform trial is, just briefly, platform trials really revolutionize how we construct and carry out trials. So a traditional trial works sort of like if we decided that we would play a game of soccer, and our first step was to sit down and design and build a stadium to play in. That means we'd need to have contracts, and we'd need to put together what we call the protocol or the plan for doing the trial. We need to reach out to all of the sites that may be a part of this. We need to design our schedule of activities and figure out how we're going to monitor safety. All of that happens freshly. And then we run the trial, one intervention for one disease. And at the end of that, we take that entire constructed stadium down. And if we want to play another game of soccer, that is, if we want to do another trial, we start from scratch. There are inherently a lot of inefficiencies there. And it turns out a lot of our trials are really very similar once we get them designed. And that brings forward the opportunity to do a platform trial. In this trial, we build our stadium once. We design a trial that is robust, that will allow us to test medications, test a number of medications, that has very robust safety profiling of drugs. And then we can run not just one drug through that, but 2, 3, 4, 5. And when one finishes, we can add another one. So the way that that works in the Healy ALS platform trial is that the trial is governed by what we call a master protocol. This is the instruction book or the recipe for the trial. It's a common protocol for multiple therapies, and that's what sets it apart. The protocol defines really the global schedules for the trial. When will people come into the clinic? What will we draw their blood? How will we monitor their safety? How will we tell whether a drug is working? What sort of outcome measures will we have? And within this master protocol, we put in what we call treatment regimens. And these are the individual therapies being tested in the trial. The regimens are added to the trial so that there are always numerous therapies being tested at the same time. When the Healy platform trial began, it began with 3 regimens, different drugs, all being tested at the same time. And we've since added more, and we'll continue to do that. There are several benefits to a platform trial, and the Healy platform trial in particular. Our estimates are that we can cut costs by at least 1/3 for each regimen, and we can cut time in half to find an effective therapy. Perhaps one of the most exciting options or benefits of the platform trial is that we can run this trial and we can offer it with less placebo and more options to participants. So when a participant decides to enroll in the platform trial, he or she would be randomized to any of the ongoing regimens. Here I'm showing the first 3 regimens, A, B, and C, but later they might be F, G, and H. They'll be randomized to a regimen. They will know which regimen they're randomized to. And then within that regimen, they'll be randomized to placebo or active study drug. Now, normally, there's a 50-50 chance of someone getting placebo, which is an inactive matching sugar pill, people often call it, or the active study drug. But in the platform trial, because of the way we've designed it, we can actually increase the chances of getting active study drugs so that there are 3 people getting active study drug for every 1 getting placebo. And in the end, because we need to have a balanced number of people on active and placebo, we then share the placebo, pool those placebos so that we have 1 placebo group from each of those regimens or 3 times the placebo, and we can compare that to each regimen. This is an efficiency that really sets the platform trial apart from any other design. We can also leverage the platform trial to learn more about ALS and to build better tools to hasten future ALS trials or future regimens within the platform trial. So we can sequence DNA and learn new insights about ALS and about pharmacogenomics during the trial. We can look at well-heeled biomarkers like neurofilaments, but we can also explore new biomarkers in blood, urine, and spinal fluid. And finally, we're using speech and digital monitoring to try to find less invasive, faster, more objective, and easier to do outcome measures to make the trial overall simpler for participants. Now, the trial has 54 sites. In general, in the past, each site would have an ethics board overseeing the study, each ethics board with its own set of questions. And that slowed down startup of sites dramatically. We now have one central ethics board that we often call the IRB. And that ethics board asks its questions, makes sure that the trial is run ethically and safely, and that flows down to all of the 54 sites, bringing a huge amount of efficiency. Now, I said that we started with 3 regimens. We've since added a 4th regimen. Those regimens are zilucoplan, verdiperstat, CNM-Au8, and pridopidine. Again, each of these are randomized 3-to-1. And at the end of a 6-month randomized portion of this trial, there is an open label extension for all of these. And that open label extension ensures that people who've been in the trial, whether they were randomized to placebo or active treatment, all have the option of receiving active study drug at the conclusion of their randomized portion. Now, the 5th regimen has already been added and is in its design phase. That's Trilahos by Selos. And we're in discussions with at least 2 more companies for 2021, if not more. Each of the treatments that goes into this trial is selected by a committee of ALS scientists and experts who really vet it to make sure that the science behind it is exciting. Now, all 54 sites have ethics board approval. It's a centralized approval process. 44 of those sites are actually enrolling participants now. We've enrolled 323 participants, and 217 are already receiving study drug and placebo. The remaining ones are in their screening period and will soon start the drug or placebo. There are 30 plus more sites that are interested in joining the trial. And one of the additional benefits of this platform trial is that the geographic spread is much greater than most trials that go on at just a handful of sites, limiting the access to people with ALS to these trials. Now, these first 3 regimens are 50% enrolled, and the trial is enrolling faster than any previous or current trial in ALS. It is really remarkable. This is a list of the 44 active sites that are enrolling as of a couple of weeks ago. And again, there's a spread across the country of each of these sites. Now, we know that this can be dizzying, so the platform trial also has a patient navigator, actually, too, Catherine Small and Allison Boulat. And they can be reached at 833-HALT-ALS by anybody across the country who has questions about how they might get involved in this trial, what's their nearest site. They can also be reached at this email address. All of this is available on the Healy ALS platform trial website as well. Now, we have a companion effort, which is the MGH ALS link, which is also available on our website. You can find the Healy ALS website by simply Googling Healy ALS or MGH Healy ALS. And the MGH ALS link is really an email list that you sign up for where we send out newsletters and opportunities to participate in ALS research and new information about ongoing or completed trials. I want to turn my attention for the last couple of slides here just to talk about expanded access protocols and how they're giving us new ways to include people with ALS in research who really in previous years were excluded. These expanded access protocols are FDA regulated, and they're designed to provide people with serious illness, including ALS, access to experimental therapies. And we're able to provide expanded safety data about experimental therapies by using data that we collect from expanded access programs. But these are aimed at people who are not eligible for clinical trials, perhaps because they've had disease too long, perhaps because it is more advanced, or they just don't have the characteristics of a person who would fit into an ongoing trial. And for that reason, they're not able to participate in this really hopeful and I think important endeavor to move the field forward. But expanded access programs are meant to fill that void. They're sort of situated at the nexus of clinical care and research. They're not trials, and yet they're not typical clinical care because they are, we hope, a source of hope and a source of excitement But at the same time, these are experimental therapies. Now, the last, I think, important part is that these are often a partnership between industry partners and academic partners and patients. They are usually supported, at least in part, by philanthropy. So, another example of really critically how philanthropy supports what we do. The Healy Center has really had a number of expanded access programs with a handful of participants in each. But over the last couple of years, we've been able to grow the total number of enrolled participants nearly up to 100 participants. This is really what we kind of dreamed of when we began these programs, and you can see they got off to a slow start and have been going much faster recently. So this is really an opportunity for people who otherwise would not have access to experimental therapies. A new program is the Healy ALS Platform Trial Expanded Access Program. And this is a collaboration with Biohaven and funded in part by IMALS. It's an expanded access program of verdiperstat, which is the platform trial regimen that's sponsored by Biohaven. And in this EAP, all participants will receive the study drug. The protocol is similar to the platform trial, but simplified so that we don't have to do as many visits, although we have to certainly monitor the safety in the same way. There are 3 platform EAP centers, Northwestern, Duke, and MGH, and this really sets it apart from the expanded access programs that I was talking about earlier, which were all single center. The plan is to have 30 participants, and it will be open to people ineligible for the main platform trial. It is in startup currently, and we look forward to this getting started. So just to summarize, we really hasten progress through scientific discovery, partnership, efficiency, and inclusivity. Basic researchers are creating breakthroughs in ALS science. These breakthroughs are translating to novel therapeutics. We're developing new ways to test these therapies more efficiently than ever, like the platform trial, and in some ways, the expanded access programs. We're working with the FDA, with industry partners, with ALS clinicians, and with people with ALS and their caregivers to ensure that new trials are better designed than ever, simpler, more available. Expanded access brings experimental therapies to a broader range of people with ALS than ever before. And with all of these new tools and everything that we're learning about ALS, the future is bright. And you'll hear some more about why the future is so bright from our next speaker, Gaz Sadri-Vakili. So I'm going to pause here, and Gaz will begin sharing her screen. While she does that, I just want to introduce her briefly. Gaz is an assistant professor of neurology at Harvard Medical School and at Mass General. She directs the Neuroepigenetics Laboratory at the Mass General Institute for Neurodegenerative Diseases. Thus far, Dr. Sadri-Vakili's laboratory has identified disease-specific alterations in multiple cellular pathways using human samples, as well as cellular and animal models of ALS, Huntington's disease, and X-linked dystonia Parkinsonism. In ALS, her laboratory is assessing the pathogenic role of neuroinflammation, mitochondrial dysfunction, and the epigenome. She works very closely with clinical research colleagues from the Healy Center at ALS to translate her findings in fundamental laboratory research into meaningful breakthroughs for people with ALS. Today, she's going to talk about ALS, the latest research and preclinical updates.
Thank you. I'm delighted to be here. Good afternoon, everyone. My name is Ghazaleh, as James just introduced me, and I'm delighted to tell you about some of the preclinical updates in ALS. If I can get this, there we go. Sorry. So here's an overview of what I'll be discussing today. I will talk about some pathogenic mechanisms, mainly focusing on protein aggregation, trafficking, and a cellular process known as autophagy, giving you 2 different examples on that, and then finishing up by telling you a story about inflammation in ALS that we completed last year. This is a pretty busy slide, but the point I'm trying to make here is that many different things can go wrong in ALS, and you can see them highlighted here with these exclamation yield signs. But what happens is that it's not just the neurons here with the cell body, with the axon. It's not just the neurons that go through these processes or have deficits in their cellular processes. It's also other cells of the CNS, such as the oligodendrocytes, astrocytes, and as well as the microglia, that can also be involved with causing pathogenesis in ALS. And because this is too complicated to look at this way, I decided to summarize these pathogenic mechanisms in the form of this colorful image that you can see here. Now, there are too many pathogenic mechanisms for me to discuss today, so I'm just going to be focusing on the ones that are highlighted here. And the point that I like to make is that a lot of these mechanisms are actually linked. So when we're studying one, it could also be involved in other processes within the cell. I'll start by talking about protein aggregation, which is a hallmark of neurodegenerative disease. Here on the left, you can see that protein aggregates are found in a number of neurodegenerative diseases, including Huntington's, Alzheimer's, Parkinson's, as well as prion disease. And here you can see two examples of protein aggregates being formed in ALS. On the right, I'm showing you the different genes that are known to be linked to cause ALS: SOD1, TDP43, FUS, and C9orf. Mutations in all of these genes or proteins will lead to different forms of aggregates within neurons. So the point I'm trying to make is that protein aggregation occurs across neurodegeneration, but also in ALS. Now, why would this happen? One of the reasons where you can have disrupted protein synthesis, or excuse me, if you can have the increases in protein aggregation, could be due to a loss of autophagy, which is a cellular trash removal system. So this is one of two different ways that we can get rid of trash within the cell. And it's really very simple. The cell will form a membrane around proteins or DNA or RNA that needs to get degraded. And you can see that happening here, forming what's known as an autophagosome that will then fuse with another organelle called the lysosome within the cell. The lysosome then has enzymes in it, and it's more acidic, which will then lead to the degradation of the unwanted proteins. So you can imagine that if you lose your trash service, then you're going to have this pileup of trash. And this is sort of what happens and how proteins could end up, one way in which proteins can end up aggregating in the cells. And what we know is that autophagy is becoming a really hot target in neurodegeneration, as well as in ALS in particular. We know that maybe if we could increase autophagy, then perhaps we could degrade some of these protein aggregates and clear them. But also we're learning that the lysosome itself doesn't fuse correctly to the autophagosome, so there's issues with that. Also, there's problems with the pH within the lysosome. So there are many different areas in which we can target this pathway. And there are a lot of wonderful labs working on these processes. So a new target, I would say that I'd like you to know about is how we can improve autophagy in ALS. And that could be one way to go about this. Another thing I like to talk about is trafficking within a cell. So just like you have this many-lane highway going in two different directions, if you can imagine, here is a very simplified schematic of a neuron with the cell body here, the nucleus, and the synaptic terminal on the other end with the axon in the center. There are things known as microtubules that are within the axons, which I'd like to think about as the highways within the cell, where you can have, where you can transport proteins and different organelles within the cell from, let's say, the cell body all the way to the axon terminal, or in reverse, just like this two-way highway. So this trafficking also occurs between the nucleus as well as the cell body. You can have trafficking of RNA and different proteins within the nucleus and the cell body. So you can imagine that if you have disruptions in any of these areas, you can have some problems. So let's focus on the nucleus first. It's been described now over the past 3 years that there are issues with the nucleocytoplasmic transport in ALS. And one protein that's really affected by this is a protein known as TDP43, which is a nuclear protein involved in transcription and RNA processing. Importantly, mutations in TDP43 have been shown to cause ALS. And TDP-43 aggregates are found in 90% of ALS cases, including sporadic cases. So in ALS, we know that TDP-43 is mislocalized to the cytoplasm. And if you remember, I said that this is supposed to be a nuclear protein. So a number of our colleagues set out to determine what does loss of nuclear TDP-43 lead to. And what they found is when you have a loss of TDP-43 that forms these cytoplasmic aggregates, what happens is it directly affects the expression of another protein known as stamin-2, which is a microtubule binding protein. So you could imagine stamin-2 being one of the cars that can take the cargo down your axons into the synaptic terminal. And stamin-2 not only binds to the microtubules, but it's also really important for axonal regeneration and growth. And what our colleagues demonstrated is that in ALS, when you have this loss of nuclear TDP-43, you can see it here in red outside of the nucleus. What happens is it leads to this degeneration of axons. And that's exactly what happens in ALS. At the neuromuscular junction, we have denervation. So stamin-2 could play a role in this. And what our colleagues are hoping to do is to reverse this and make it more like a normal situation where you have nuclear TDP-43. So stamin-2 is a new target now, and our colleagues are working hard to replace it or replenish it and perhaps help in regenerating the neurons and helping with the denervation that happens at the neuromuscular junction. Okay, what else can go wrong in terms of trafficking and bringing together with protein aggregation? You can imagine if you have a pileup on your highway or you have a bunch of proteins aggregating on your microtubules or in your axons, then perhaps you're not getting the cargo where it needs to go, whether it's the synaptic terminal or even in the cell body. So now new studies from my lab are focusing on another protein that's a microtubule binding protein, and it's known as tau. Now, you may have heard about tau if you were listening to the earlier talks on Alzheimer's disease. Tau stabilizes axonal microtubules, is important for trafficking, and it's been implicated in Alzheimer's disease. Not only that, tau has been shown to aggregate in a number of neurodegenerative diseases, and those neurodegenerative diseases are known as tauopathies. So I'm not going to tell you that ALS is a tauopathy. However, we have begun to notice that tau is also aggregated and hyperphosphorylated in ALS, similar to what's known in other diseases. So what we found is similar to Alzheimer's disease, tau is shifting from the cytosol to the synapses. So it's shifting from this area of the neurons to the outer areas. And when that happens in Alzheimer's, we know that this hyperphosphorylated mislocalized tau could be toxic for the neurons. And it could be toxic because it can increase synaptic loss, but it also has been shown to interact with mitochondria. And I'm going to tell you more about that. So we hypothesized based on these preliminary findings and also what's known in Alzheimer's disease that alterations in tau could play a role in mitochondrial dysfunction in ALS. And perhaps if we could target tau, we could reverse these abnormalities. As you know, mitochondria are the powerhouses of the cells. They produce energy, but when they're not working properly, as they don't in different neurodegenerative diseases, there's a decrease in ATP or energy production, there's a decrease in calcium buffering, and also mitochondrial dynamics, their shapes themselves are altered. More importantly, they non-functioning or dysfunctioning mitochondria can increase there's an increase in the reactive oxygen species or ROS, which could end up being really toxic for the cells. So talented postdoc Tiziana Petrosiello in my laboratory started to assess mitochondria and the role of tau in altering mitochondria in ALS. And using electron microscopy, she was able to show that in postmortem brains from ALS patients, there is a decrease in the number of mitochondria, but not only that, that the mitochondria that were there were actually smaller. So there's an increase in the number of smaller mitochondria. suggesting that mitochondria are smaller and fragmented and perhaps less energetically favorable in ALS, as we know. So we wanted to know what is the mechanism that causes this fragmentation in ALS. And I was just describing to you that mitochondria are very dynamic. They can fuse together and form these larger networks, which are more energetically favorable, or they can go through this process called fission, where they're fragmented and form these smaller mitochondria that could then be degraded more easily. And this can occur through the activity of a protein known as DRP1. What we found when we measured DRP1 levels in postmortem brains from ALS patients is that there was a significant increase in DRP1 levels that went hand in hand with those smaller mitochondria that I was showing earlier. Because of time, I don't have, I can't show you all of this data, but I want to leave you with this, that we found that alterations in tau and DRP1 are common mechanisms across ALS. We've looked at them across a large postmortem sample size, whether they're male or female patients, or if they had TDP-43 aggregates or not. No matter what type of ALS it was, bulbar onset, limb onset, we found these differences in tau and DRP1. So then we wanted to know if the synaptoneurosomes that are enriched in tau and DRP1 could alter mitochondrial dynamics, and we set up an in vitro assay. So we're using cell lines here and treating the cell lines with synaptoneurosomes derived from ALS patient brain or control brains that were from healthy individuals. And we're using here a recombinant tau as a positive control. And when we treat cells with these different conditions, we find that the ALS synaptoneurosomes and the tau alone can cause shattering of the mitochondria. So here you can see that there is a significant increase in the number of smaller mitochondria and that there's a decrease in the number of larger mitochondria. Not only that, we find that there is a decrease in the number of large networks, mitochondrial networks, and that the number of the mean branch length is also decreased following treatment with ALS synaptoneurosomes or tau, suggesting that, again, tau and DRP1 may be playing a role in this. So then we wanted to know, if we target tau, if we degrade it, can we mitigate these changes in mitochondrial dynamics? Here we're working with our colleagues, Dr. Haggerty and Dr. Silva at Mass General Hospital, that are using this new technology called proteolysis targeting chimeras, or PROTACs. This is a way where you can degrade your protein of interest. And I think over the next few years, we're going to be hearing more and more about this novel technology. And they have developed a novel degrader where I'm just going to call it QC. You can see it here, just to be brief, but QC is able to degrade tau and phosphorylated tau levels. And so we're using that here to treat ourselves and show you that we can significantly decrease tau levels following treatment with QC. So we wanted to know, if we degrade tau, how does that affect the mitochondria? And as you can see here with these solid bars, the solid bars are now the ones that got treatment with QC. We're actually able to mitigate the effects of tau or ALS-derived synaptoneurosomes. So by degrading tau, we're able to decrease the number of smaller mitochondria and also increase the number of larger mitochondria. And the same thing we're seeing with the networks, we're able to reverse the effects of the ALS synaptoneurosomes and tau by removing tau and restoring the mitochondrial networks. Now, does that have any functional effects or not? The answer is yes. So I showed you, or I told you earlier, that when mitochondria are dysfunctional, there is an increase in reactive oxygen species, or ROS. And what we're able to do is, when we degrade tau, then we can restore or decrease the amount of reactive oxygen species that were increased in response to the treatments. So in summary, we think that phosphorylated tau and DRP1 interact together in ALS, causing the formation of smaller mitochondria and increasing oxidative stress. And if that we target tau, we're able to increase the size of the mitochondria or get rid of the smaller mitochondria, and also decrease oxidative stress and reactive oxygen species. And in the last minute, I just want to touch upon inflammation or neuroinflammation, which is also one of the pathogenic mechanisms that we talk about in ALS. We know that inflammation occurs and it's important for disease progression in ALS. A number of different inflammatory markers are altered in ALS. And here on the right-hand side, I'm showing you a brain from an ALS patient versus a control. This is a PET scan that's specific for a marker of inflammation. You can see the more red and yellow you see, there's more binding of that marker to the brain. You can see that happening in a patient living with ALS, that there's more inflammation in their brain compared to a healthy control. So we have different ways of monitoring this and measuring it. So the thought is, if we could mitigate this, if we could decrease inflammation, perhaps we could help with neuronal survival. This is, again, a busy schematic, but what I like to show you is those microglia that I talked about in the beginning, or the glial cells, they can become reactive and cause more inflammation. And we know in ALS that there is an imbalance between the homeostatic glial cells that are supposed to be there supporting the neurons, and the ones that we call reactive, which end up releasing a lot of pro-inflammatory cytokines and chemokines that could cause neuronal death and injury. So if we could balance this out to decrease these reactive glia and make them more homeostatic, then perhaps we can balance it. We can balance the immune response. And one compound that's known to do this is called cromolyn sodium, that we did a whole preclinical trial in our transgenic SOD1 mice with this drug. And what we showed is that treatments with cromolyn could delay disease onset in the SOD1 mice, that it was neuroprotective and it spared the spinal motor neurons, and it also maintained innervation at the neuromuscular junction. Importantly, cromolyn was able to reduce inflammatory markers and mast cell activation, and mast cells are actually a direct target of cromolyn. And this was really exciting because the company that had provided the compound for us, AZ Therapies, started a clinical trial using cromolyn this past September. They dosed their first patient in a phase 2 clinical trial. So this is just an example of what we do in the lab and how we can translate it into actual clinical trials for the patients. And I feel really lucky as a basic scientist to work with Dr. Berry and, Dr. Babu at the Healy Center, so that we could translate some of our basic science findings to the clinic. And I will stop there and pass it back to Dr. Berry. Sorry, before I do that, I'd like to thank everyone in my group who does the work, and also my wonderful collaborators at Mass General Hospital, our sources of funding and other collaborators, and of course, patients and their families. And I'll stop there. Thank you.
Thanks, Scott. Really wonderful dive into some of the biology, and hopefully we'll get a chance to talk a little more about some of that in the question and answer session. I want to introduce Suma Babu, who is an assistant professor of neurology at Harvard Medical School and Mass General. Dr. Babu is an active clinician in the multidisciplinary ALS clinic at the Healy Center for ALS. She has a special interest in developing disease-modifying treatments and in using neuroimaging, including positron emission tomography and MRI scans, to characterize neuroinflammation and other markers of ALS disease mechanisms in people who are experiencing the disease, where our research is really most relevant. Dr. Babu leads several phase 1, 2, and 3 clinical trials evaluating novel therapeutics for sporadic and familial ALS, in addition to her work in neuroimaging. And today she's going to talk about new hopes for ALS, a new era of clinical trials and novel approaches for clinical care.
Thank you, Dr. Berry. Good afternoon, everyone. I'm excited to be here for this virtual event today. I'd like to give a bird's eye view of some of the exciting developments that's happening in the field of clinical trials, as well as in the field of clinical trial readouts of biomarker development, and also to include some new initiatives for expediting the diagnosis of ALS for patients as well. So this is the agenda for today. As Dr. Berry mentioned earlier, drug development for ALS is rapidly accelerating. And today in the drug development space, there are more than 160 companies developing drugs for ALS. In addition to many phase 1, phase 2, and phase 3 trials that are ongoing, more recently, we learned about 2 successful clinical trials that were published just within the past year. One of them is a gene therapy approach using a drug called tofersen for people with SOD1 mutation ALS. And the second, as you heard earlier from Dr. Berry as well, a drug called AMX0035 for people with ALS. Tofersen is an antisense oligonucleotide. In short, we call it as ASO, for people who carry a mutation caused by SOD1 gene. This drug is being developed by Biogen in collaboration with Ionis and several academic institutions, including MGH. In their phase 1 trial that was published just within the past year in the New England Journal of Medicine, tofersen was shown to be safe, and there were some early signals of slowing of disease progression in people who received tofersen at the highest dosage and who carried the SOD1 mutation ALS. So what is tofersen and how does it work? In SOD1 ALS, there is excessive production of a toxic protein, the SOD1 protein, as you heard from Dr. Sadri Vakili earlier. And this clogs up the system within the motor neurons. It is tofersen is a drug that binds to this toxic faulty RNA that could produce this excessive amount of the toxic SOD1 protein. It blocks it from producing the excessive amount of the SOD1 protein and hence rescues the motor neuron cell. In the trial, the phase 1 trial, people who received the highest dosage at 100 milligrams, compared to people who received placebo, there was a lowering of SOD1 protein to the extent of 33% as measured in their cerebrospinal fluid, compared to people who received placebo who had only a 3% reduction in the toxic SOD1 protein levels. That's very exciting, and what it translates to from preclinical studies is that 33% reduction is clinically meaningful and relevant. What we also learned from this trial is that there were some early signals of slowing of disease progression as measured by ALS-FRS-R or vital capacity changes. We should keep in mind that this was a phase 1 trial primarily looking at safety and tolerability. And even in the small group, as using as few as 10 people who received the highest dosage, there were group differences between people who received the actual drug versus placebo in terms of slowing of ALS-FRS-R decline, as well as slowing of the vital capacity decline. And when we looked at smaller subgroups of people who had a rapidly progressive disease, the group difference became more exaggerated for both ALS-FRS-R as well as for vital capacity changes. This is very exciting for the field of genetic forms of ALS. Currently, tofersen is being tested in a phase 3 trial, and this trial is ongoing, and we're awaiting the completion of this trial, which probably would happen later this year. So what's next for genetic ALS? Just within the past decade, there have been more than 10 new genes that are discovered for ALS. One could also look at this as 10 new targets that we could target using the antisense oligonucleotide or other mechanisms of gene therapies to help people who have these genetic forms of ALS. Following the footsteps of tofersen, there are additional ASO clinical trials that are currently in trial, actively recruiting, or in the pipeline. The most common gene causing familial ALS in the US, which is a C9 ALS, or C9orf72, in short, we call this a C9 ALS. This ASO program is in phase 1 currently, and Ataxin-2 is another ASO program that has just recently started, and later this year, we're also hoping to see FUS ALS ASO program to start in its phase 1 trial as well. So overall, the landscape for gene therapies and genetic testing is really rapidly expanding. And keeping this in mind, I would encourage all patients on this call to please discuss with your neurologist if genetic testing or gene therapy approaches might be the right approach for you. Moving on to the second positive trial that was published in the past year, also in the New England Journal of Medicine, was the AMX0035. And this is a phase 2 trial. It's a combination of two drugs, phenylbutyrate and Turso or TUDCA. AMX0035 in preclinical studies showed that it can rescue motor neurons based off of the individual component drugs that can work on two different cell organelles, the mitochondria as well as the endoplasmic reticulum. As you heard from Dr. Cedars-Sinai earlier, targeting the powerhouse as well as the trash removal system within the cells. And what we learned from this study is that AMX0035 is safe, and it showed that a slower functional decline in people who received the actual drug compared to placebo over a period of 24 weeks. This trial was led by MGH. Dr. Sabrina for this study was of ALS community. The drug was produced from Amylyx Pharmaceuticals at many different sites. The trial was conducted at many different sites within the US. What we learned from this trial in terms of the primary endpoint is that the ALS-FRSR decline over a period of time was slower in people who received the drug. That's the red bar you can see on the slide at the top, compared to people who received the placebo, which is the blue bar who had a greater progression over the trial duration. And this difference between the drug and the placebo groups was statistically significant at the end of the trial. Further, what we learned is in the open label extension, there was a survival benefit in addition to people who received the AMX0035 who were randomized to this drug in the original study compared to people who received the placebo. In general, there was about a 6.5 month longer median survival in the group that was originally randomized to AMX0035, and the risk of death was about 44% lower in this group. This is all very exciting for the field of ALS and clinical drug development. As we bring more and more drugs to clinical trials, it's also important to think about newer clinical trial readouts and biomarker developments, especially in the earlier phases of drug development. If there's a way we can develop biomarkers that can tell us the mechanism of the disease that is driving the disease in different patients, and if we can tell if a drug that is targeting the disease mechanism is actually reaching the target or not, I think that would add a lot of value in accelerating drug development for ALS. One such biomarker is the PET target called as PBR28. You saw an earlier image that Dr. Cedars-Sinai showed about inflammation in a patient with ALS compared to healthy controls, and there was a PET marker that showed increased inflammation in the brain compared to healthy controls. And that PET marker is PBR28. And our group has been using this PET dye for the last decade, and we've scanned over 200 people with this PET dye, and we have scanned ALS patients, many different types of motor neuron diseases, and patients who are at different stages of ALS illnesses as well. What we have learned is that when we look at the ALS group and compare it with people who don't have ALS, there is increased inflammation in the brain. And the inflammation is not everywhere, it's focal, and it is very robust in the region what we call as primary motor cortices. This is where the upper motor neurons reside, and this is a site of disease biology in ALS. What we also learned is that this inflammatory signal is more robust in people who have faster disease progression, and also in people who have more upper motor neuron signs clinically that manifest either as brisk reflexes when your doctor examines you using reflex hammer, or people who have more spasticity or stiffness in their arms and legs. Recently, taking this experiment, a series of experiments a little bit further to see if we can actually design a multi-site study where not every site may be producing the same PET dye, the PBR28 dye, not every site may have the same scanner as we do. Is it possible, is it feasible for us to combine the data across different sites as long as the dye is still targeting the same primary target protein, which is the TSPO protein, which is present within the mitochondria of inflamed cells within the central nervous system. We collaborated with a group in Belgium who were doing similar experiments using another tracer called DPA714. And we combined the two data sets and we looked at whether this increases the power of detecting inflammation in the combined data set. And this is the image that you're seeing that was published last year that shows that in comparison to each individual data set, the combination, when we pulled everything together using a state-of-the-art analytical pipelines are automated and a standard template space to analyze these data, the power to show inflammation within the motor cortex and the supplemental motor area increases a lot. This is very exciting. What this means for the field is that if we were to develop clinical trials using imaging biomarkers, people don't have to travel all the way to MGH just to do these studies, but they could potentially participate in sites closer to their home if they have the capabilities to, if a site has a capability to produce and run these studies closer to home. More recently, PBR28 PET was also used in a clinical trial in Parkinson's disease using a drug called verdiperstat, which you heard about from Dr. Berry earlier. It's also in the platform trial. It's a potent myeloperoxidase inhibitor as an anti-inflammatory medication. What we learned in the Parkinson's disease trial is that PBR28 PET signal reduced by about 60% as early as 8 weeks. To inform that the drug is able to reach the target sites as early as 8 weeks, and this reduction was mostly seen in areas that are clinically relevant for Parkinson's disease. This is also a very exciting new development in the field of PET biomarker development, and using this information, as well as all the experiments that are ongoing in ALS, PBR28 is currently being used as a clinical trial readout in several early phase clinical trials. Currently, we have an exciting trial that's ongoing that using a drug called BLZ945, which is also a very potent anti-inflammatory medication. And this trial is sponsored by Novartis. And if anyone's interested in participating in this study, please feel free to reach out to me. A biomarker development program such as this requires a lot of people to collaborate and help with the development of this program. So it really takes a village to develop biomarkers. And in addition to colleagues at the Martino Center as well as at MGH, there are several patients, families, and funding supporters who have helped to continue this program currently. I'm going to shift gears just a little bit to think about, as we're developing biomarkers and drugs, we do need to expedite the diagnostic timeline for ALS patients. There is a tool that we are developing called as a Think ALS tool, which is targeting general neurologists or family physicians to create more awareness and educational resources for suspecting the ALS, as well as referring patients to multidisciplinary ALS clinics expeditiously. Currently, in the US, it takes about 12 months for an ALS patient to have a confirmed diagnosis of ALS from the time of symptom onset. This is a really long time. And our goal is to really shorten this timeline so that patients can have early access to FDA-approved medications, as well as early access to experimental therapies. And one of the barriers to early diagnosis is awareness at the first level of physician contact that patients may have in terms of suspecting ALS at the very beginning. Initially, it may be thought to be something unrelated to ALS, maybe carpal tunnel syndrome, or maybe a neck problem. And how can we improve this awareness and education among general clinicians to diagnose or think about ALS? And this is a tool that was put together as a national initiative that was led by ALS Association. And there's a working group that included many patient representatives, physician scientists, as well as industry partners. And we developed this tool that has information about when to suspect, when not to suspect ALS. And in addition, also provides resources in terms of when you do suspect ALS, how do we make the referral to a multidisciplinary ALS clinic expeditiously and really shorten that timeline to that first ALS consultation, and also provides resources for general neurologists or clinicians to find the nearest multidisciplinary ALS center close to where the patient lives. So that's my last slide. And with that, I will stop sharing. Thank you.
Wonderful. Thank you both for those presentations. This is when we're going to transition to the question and answer session. Really exciting things. I mean, I hope that everyone in the audience sort of gets the flavor that there are just incredibly exciting things happening in ALS, and we'll be able to dive into some of these a little bit more in just a minute too.
Okay, our first question of the day is, can you talk about some of the barriers to diagnosing ALS?
Thanks. So Suma, this really, I think, dovetails really well with kind of the last topic that you covered in your presentation. And I wonder if you wanted to start the conversation to talk about this.
Absolutely. That's a great question. And it is a hot topic. And I would say that first and foremost, the biggest barrier to diagnosing ALS is that we don't have a definitive diagnostic test that we could run to say this is ALS. For example, if you have to diagnose somebody with heart risk, you can run cholesterol levels. Somebody to diagnose with diabetes, you can look at blood sugar levels or hemoglobin A1C. We don't have a hemoglobin A1C test for ALS. And it still primarily is a clinical diagnosis, and there's so much heterogeneity in the disease manifestation itself. So, and that leads to delays in reaching the confirmatory diagnosis for ALS. And then to add to that, I would say, in addition, is that the biomarker development, which is not just a diagnostic tool, we don't have specific or sensitive biomarkers yet that would tell us, is this ALS? Could this differentiate from other diseases? And what type of ALS this is that a patient might be experiencing?
Yeah, I guess I would add to that you know, ALS is an uncommon disease, and so you know, there are estimates that primary care physicians see on average one case of ALS throughout their career. And of course, you know, some will see more and some may not see it at all. On the other hand, people coming into a primary care physician to say, you know, my arm feels weak, or there's something, you know, my voice has changed a bit, is much more common. And so this is, I think, why we really, just to underline your point, Suma, that we need sensitive and very specific markers that, you know, hopefully could be done easily and cheaply, so that we could really kind of find those potential cases early, but without raising the specter of ALS, you know, unnecessarily for people that are dealing with a different problem. And I think that's the kind of biomarker that we're looking for. And Gaz, I guess I would turn to you for just a moment and say, you know, we've worked on biomarkers together, and tell us a little bit about, you know, the work of looking for biomarkers and what that means in the lab.
Sure, yes. I mean, that's one of the things that we try to do in the lab in collaboration with our clinical colleagues, to use biofluids from patients, whether it's plasma or cerebrospinal fluid. You can actually use urine as well. When we, you know, we always try to go back and start with the postmortem samples from the patients. When we find a pathway that's dysregulated, like some of the ones that I was showing you today, and I'll just focus on tau for a minute. Tau is being used as a biomarker for Alzheimer's disease, or at least it's being developed as a biomarker for Alzheimer's disease. So one of the things that we did when we found that tau is also dysregulated in ALS is to measure tau levels in CSF or cerebrospinal fluid from ALS patients. So by doing those types of studies, but actually you need to have large sample sizes to make sure that this is happening across all cases, that you have the power, and that this is going to be something that holds up. That's the kind of studies that we do in the lab. So once we think that something might be a good marker for disease, then we can go after it and measure it in different types of biofluids. Having said that, do we want something that's specific for ALS? So, as I said, tau is altered in a number of neurodegenerative diseases, including ALS. Does that make it a bad biomarker because you can measure it? It's altered in many different cases. It's probably not the best diagnostic marker, but perhaps we will have several different things that we can measure at the same time. If you drew blood from a patient or if you took their cerebrospinal fluid, if we had 2 or 3 different proteins that we could measure that would be altered, then that could give you an ALS signature type of biomarker. So those are some of the things that we're doing and thinking about currently. And I'll stop there.
Yeah, no, that's great. I mean, that's perfect. I think just understanding a little bit about what goes into developing a biomarker or thinking about a diagnostic biomarker is really critical. One place that this starts is having what we call biofluids. It's an unusual word for people who aren't in the field. It's kind of a term of art. And but basically taking blood and then we separate that into its fractions. Plasma is the liquid part. We all know about cells, but there are red blood cells and white blood cells. Each of those parts could be really important to us as we develop these. You mentioned urine. There are actually some potential biomarkers in urine that are being explored. But I think the key is that having these allows us to explore them. And so that our conversations about these projects often begin with what samples do we have. And so one way that people with ALS and people who don't have ALS can get involved is by donating biofluids or being involved in studies. And these are also studies that are often not particularly, at their outset anyway, often not the ones that sound the most exciting and are the easiest to fund. And so sometimes a little bit of philanthropy funding in the beginning can get us going into bigger projects that then are kind of more exciting to funding agencies. So lots of ways that people can be involved.
Okay, next question. Is ALS classified as an autoimmune disorder?
Yeah, I think I may start with this and then sort of hand off. I think, probably Suma does a lot of work in imaging the immune changes, and Gaz does a lot of work with looking at the biochemistry. Let me give a few thoughts on that just from a clinical perspective. Not so many years ago, 99% of people in the field would have said that the immune system was unaffected in ALS, and that it was not an autoimmune disease because the immune system was unaffected. I think that has really changed dramatically over the last decade, so that now the prevailing thought is that absolutely the immune system is affected. It's what we call dysregulated. So the wheels have come off in some way. It's not functioning the way that it should. I think it's important to say that there are very specific ways in which that is true, and in some, compared to some diseases, subtle ways in which that is true. It did take us a very long time, and we needed to have the right measurement tools to be able to see those abnormalities in the immune system. There are differences between ALS and other diseases that we would call autoimmune diseases, like rheumatoid arthritis or lupus or multiple sclerosis or Guillain-Barré syndrome. In that we don't know for sure in ALS that immune dysregulation is the match that starts the fire. It may well be like having gasoline in the house. If a fire starts, that's a very bad thing, and less like the match that starts the fire. And so that may be a fundamental difference between ALS and what we think of as classically autoimmune diseases. But those lines are blurring a little bit, and our language may need to adapt. Why don't we hand it over maybe to Suma to talk a little bit about, you can talk a little bit about your imaging and what that means, and then Gaz, you can maybe tell us about the molecular perspective.
I completely agree with you, Dr. Berry, about classifying ALS as an autoimmune versus a dysimmune process, and going back to what Ghazali, you had said earlier, that mechanisms are linked and they can overlap. No matter what triggers the disease up front, eventually there's a cascade of multiple different mechanisms that flow, and then there could be the immune system that is involved in many different ways in the disease progression or even perpetuating the disease. From an imaging standpoint, we're targeting inflammation, and the inflammation is of two kinds. One that pertains to glial cells that live within the central nervous system, but there could also be inflammatory cells or immune cells that flow into the brain from the periphery, from the blood, that could also be a part of that inflammatory process. The inflammatory signal that we are seeing on PET imaging and that correlates in many ways the clinical disease progression, as well as the clinical signs of upper motor neuron burden, again points to the fact that there is immune mechanisms that are involved, whether or not they are the key drivers of disease, clinical disease in an individual or not, it remains unsettled at this point in time.
And I would just add that going back to more of the peripheral biomarkers, such as cytokines or chemokines, things that are known to exacerbate immune response, it's kind of hard to know because there's so many studies that have been done looking at these markers in blood and cerebrospinal fluid, and we don't really have a clear answer on who are exactly the players that are, for example, increased that could cause inflammation. We don't really know that. And I think the immune system is really hard to hone in on, in the sense that many things can cause changes in our immune response, right? So you can have an infection, or even the food that we eat could alter our immune response. So as James said, we know that it's dysregulated, but whether or not it's the same type of autoimmune disease that we see with multiple sclerosis, for example, we're still not sure, because the key markers that would be elevated in autoimmune disease are not necessarily altered in ALS. But as James said, maybe we need to start thinking about all of this in a different way. And maybe there might be some immune component to that, autoimmune components that we don't really know yet, but it's not your typical autoimmune components that you're seeing with your autoimmune diseases. And the biochemical molecular studies would suggest that as well. But I think we're just learning more and more about neuroinflammation and what's happening in the periphery versus what's happening centrally in the nervous system. So I think we'll probably have a better understanding of all this over the next few years, because people are really working on it now.
Question 3. Are there any natural remedies for ALS?
So well, I think we can all sort of chime in on this. I think this is a tricky one. First of all, I guess it depends a little on what we mean by natural, and also by what we mean by remedies. I think that there aren't, we don't know of cures for ALS that come out of naturopathic or sort of herbal medicine. However, there are many things that are not just medicine, not just sort of Western medicine, that are helpful for people with ALS. To start with very simple things, diet and weight, we think, are really important. It's very important that people maintain their weight, we think. And there are some studies showing that maintaining weight is a really important thing. Interestingly, we don't have a lot of studies guiding us to a kind of diet that's important, rather that people not lose weight seems to be important. There are some studies going on of supplements, everything from curcumin to TUDCA to alpha lipoic acid, to a number acetyl L-carnitine, a number of other kind of supplements that are giving us some hints, at least early in studies, that maybe there's some benefit there. I want to be clear that there isn't proven effectiveness of these, but there may be, there are these trials that are showing us maybe hints. And so I think that in part the answer is maybe there are things outside of designed drugs that are from pharmaceutical companies that could be beneficial. I'll pause there and hand it off, and maybe we might have to go around a couple of times because this is a big topic.
James, I would add to what you said is, yes, this is a big topic, and the boundaries are a little bit blurred in terms of defining natural remedies as well, and to what extent, what combination, and for how long are all questions that come up very frequently in clinical practice as well. And the approach that I've taken also in my clinic is, as you said earlier, good balanced diet, healthy diet, maintaining good nutrition and weight are all important, whether that means in addition to taking the caloric intake of and proteins and carbs, should we also think about supplements, vitamins as well. And in general, the approach I've also taken is if there's no downside to some of the vitamins and supplements, there's no safety concerns with some of these supplements, and people with or without ALS are taking these supplements routinely, then it should be okay to take some of these, whether it's just curcumin or vitamins or NAD or other supplements. And then the role of microbiome and diet also is important, and that is being discussed a lot in neurodegenerative conditions, not specifically just in ALS alone. And that goes to, again, the type of diet and, again, eating a healthy, balanced diet that would affect the microbiome of an individual probably plays a role in regulating some of those immune processes as well, and helping to some extent. Gasly, I'd like to hear what your thoughts are.
I will just say a few things because I talked about reactive oxygen species and oxidative stress. I mean, I think we all might take a lot of things that already address some of that. So different vitamins like vitamin C, D, E, those are all known to be antioxidants. They could decrease your reactive oxygen species or coenzyme Q10. Inosine, these are things that you hear about, or maybe you can go to Whole Foods and like pick them right off the shelf. As long as James and Suma were just saying, as long as they're not going to be harmful, perhaps they could be, we know that they molecularly, they're hitting the right targets. There aren't too many studies on them. However, what we know about the mechanism of action of some of these vitamins would suggest that they would be good antioxidants. Or, for example, coconut oil can help with energy metabolism, for example, and we know mitochondria are dysfunctional. So based on some of the molecular pathways that we know to be disrupted and what these supplements do, then, you could make an argument of how they could be more helpful, perhaps. But then again, keep it in mind that you should always talk to your neurologists, your clinicians before you take any of these things.
Yeah, I think that, so, I wanted to make sure that we got that in, that, there are lots and lots of choices here. Some of these things that are even available over the counter have side effects, and it's really important that if people are going to go on a journey of looking for some of these things, that they do it in conjunction with a physician, and it ought to be I think a relationship where you should be able to talk about these things with your care team. So, really, 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 we encourage you to talk with your treating physician and treating team before making any of these decisions. Suma, I just wanted to touch on the microbiome because I think it's a really, really, it's a really sort of exciting developing area. Our close colleague Katie Nicholson is leading a project in this, recently published on this, that project has guided us along with others that have been done with in labs around the world, really guiding us to think that maybe there are some alterations that are important in the microbiome. And the project that Katie led really was started with philanthropic money and would not have come to the answers that it did without support from philanthropy. And it's a perfect example of a project that's impacting our thinking and wouldn't be here without philanthropic support.
Next question. Are there any signs or symptoms that indicate rapid progression or nearing end of life?
Suma, do you want to start us out here?
I can take lead on this question. I would start off by saying that ALS is a very heterogeneous disease. Some people have slowly progressing disease. Some people have fast progressing disease. And almost everybody has periods along their ALS journey where there are long plateaus where the disease doesn't progress, and there may be some times when the disease may seem like it's rapidly progressing. And that makes it very difficult to have one measure or outcome that would tell us how do you define rapid and how do you define slow. Sometimes we think about in genetic forms of ALS, if there are known or variants or mutations that are known to have rapid course with multiple family members or multiple individuals across families, that may be associated with rapid progression. So that would guide us to say in terms of prognosis and what to expect down the road. But other times we may use some of the outcomes that we typically use in research studies, again, mostly as a research outcome measure, where we've created arbitrary cutoffs to say with ALS FRSR scores, if it is greater than a certain number, if somebody is declining greater than a certain number of points per month, that might indicate rapid progression. But I've also seen if you use ALS-FRSR for disease progression, there may be several months where there may not be any change in the score, and then there may be over the next 2 or 3 months multiple points that somebody might have declined over a period of time. So it makes it very hard to put a single estimate, single measure that way. James, would you like to add?
Yeah, I think so. I mean, I think those are all really good points. I think. One of the key points is that unlike the stock market, past performance does actually predict future performance a bit here. So that, when we get a sense of how things are progressing, that tends to be how things progress within an individual. There are these plateaus and stair steps, but we can take a step back and say, how steep is a staircase? And that, and I think, that can be an important point, but that only becomes obvious over time, is the progression kind of more rapid or not. I think one thing that sometimes we run into people fearing is that they will, that one day things will change dramatically for them, and that will be sort of the day when everything is different. That tends not to be the way that ALS progresses. Now, there could be other health problems that happen, and that can be unpredictable. But that's not the way that ALS tends to progress. That people are suddenly wake up and are unable to perform some function that they could perform the day before. So I think that's an important point as well. And that the tools that we have to help people with ALS actually do make a difference in people's lives, and the sum of those tools is that people can have a better quality of life and live longer now than they did in the past. I think that's a really important thing to keep in mind as well.
Just two more questions. Can you please talk about resources that are available for patients with ALS?
Yeah, this is a big one, but also a really important one. Let's start out by talking, I think, about the key resource, which is the multidisciplinary ALS clinic. Now, not everyone is in a geographic location where they're able to access a multidisciplinary ALS clinic. Increasingly, at least over the last year, telemedicine has been a wonderful way for people to connect with multidisciplinary clinics when they couldn't before. And our hope will be that that resource will remain in place. I think, you know, if anyone had an eye toward advocacy, some of the restrictions on telemedicine that were lifted for the pandemic may go back into place unless we really put some concerted effort into changing regulations around this. That is, we cannot practice across state lines, even using telemedicine, because our licensure is state by state. And without some big fix to that, we may be in a bit of a bind. I say this only because the multidisciplinary ALS clinic is really the standard of care for taking care of people with ALS. And it is the resource that brings together physical therapists, respiratory therapists, social workers, physicians, PM&R, neurologists, pulmonologists, orthopedists, you know, psychologists, you know, really a host of resources, and can really guide a person with ALS and their caregivers to kind of what to do in real time. And I just don't, you know, we don't want people to have to go without that resource, and too many people do. It doesn't mean that, you know, I think a lot of times people visit a multidisciplinary clinic periodically, and then their local, you know, local healthcare provider carries out a lot of those plans. But I just think it's a really important resource, and I would never want to underestimate that. Having said that, there are lots of other resources, and Suma, I might hand it over to you to talk about some of the other resources that are available for people with ALS.
Absolutely, James. I completely agree about the multidisciplinary. I always say that that's at the converging point of multiple different resources that a patient can get access to or learn about. And even taking our own multidisciplinary clinic, for example, if somebody comes from a certain zip code and we're trying to figure out who might be the nearest physical therapist that we could refer them to, our physical therapists have built a network of PTs across various different zip codes in Massachusetts and around, and it will be very easy to guide, and also for them to be as a point person to guide the local physical therapist who may not know a lot about ALS, to say what is appropriate and what isn't appropriate in terms of goals and exercise regimens and so on and so forth. If I take a step back and also think about resources, it could be in many different shapes and forms. Sometimes resources can be in the form of social network resources for patients, in terms of support groups, in terms of local not-for-profit ALS associations or community resources that way. Resources can also be in the form of thinking about loaner closets to gain access for certain equipments and things like that, or even groups like IMALS or Gleason Foundation and so on and so forth, who help with a variety of different types of resources for patients. Also, resources can be in the form of online resources such as clinicaltrials.gov, where if somebody's trying to look for what type of clinical trial is appropriate for me, where I live or close to where I live, or for the type of ALS that I have. or even a website such as even the Healy Center website that provides so many different educational materials for, should I be thinking about a G-tube and what goes into making a decision about G-tube, or even a resource such as the MND Association, the NEALS. And so there are so many web-based resources as well that patients and families can take advantage of. And the list just keeps growing in terms of what might be all the types of resources that patients could have access to.
As you use Twitter a lot for science, and it's a really powerful tool to share scientific ideas amongst researchers. I use Twitter for the weather, but I have a healthy uncertainty, I guess, about social media. I wonder whether you would talk a little bit about how you, as a scientist, and I think it applies to kind of how we think about this broadly for patients. How do you approach social media and science?
Very carefully, I would say. Honestly, I would say that I'm on science Twitter to really learn about like the latest findings. As you know, there's a lot more preprints coming out on bioRxiv and medRxiv, and I use Twitter as a source to be able to, really read this new science like hot off the press. It sometimes it could take a year before scientific findings could be accepted in a journal that can then be consumed by all. So, being on there allows me to see that. But also, I use it to talk about some of the work that we're doing in the lab. I would say with everything social media, you should take it with a grain of salt, but I follow, I believe all the ALS foundations that are on Twitter. And, I think that they're a great resource. They, I know Healy Center puts out a lot through our MGH Neurology Twitter Twitter site or handle. So it's just really great to stay on top of all the events that are happening, all the different symposia, all the different types of educational programs that they have. Niels also has a great Twitter presence. So I really use it to find out what's happening, who's doing what, and what's the latest to find out.
Yeah. So it sounds like, yeah, no, I mean, I think it's really a growing resource, and kind of leaving us all to sort through how do we make all this work. But it sounds like you have trusted resources within social media that you kind of go to, and so
absolutely. I think all the foundations do such a wonderful job, and yeah, definitely to be trusted.
Yeah, I think that's sort of been our approach to thinking about this as well.
One other resource that I would point to, again, going back to the multidisciplinary clinic, is many multidisciplinary clinics, just like ours, they provide patients with welcome packets, and that may have a lot of information and resources all compiled in one place as well. Also not to forget the MGH ALS link that patients could subscribe to, and we constantly update our patients and families about new developments and new information as we learn in ALS as well.
We called it the link. We thought a lot about that name, and we called it the link because we really what we don't want is sort of isolation. What we really want people to, one of the big social determinants of health is connectedness, and so I think looking for those ways to be connected is really, really important.
And the final question: can ALS be prevented?
Also a really, really big one. The answer right now is that we probably don't have the tools right at this minute to prevent ALS, but it's we wanted to dig into this last because it is such an important area, and we are learning again through projects like the Dominantly Inherited ALS project, which is run by Tim Miller at WashU and by Katie Nicholson at Mass General. But other, similar projects are enrolling people who are potentially at risk of a genetic form of ALS before they develop any symptoms, and doing that in a very, very careful and thoughtful way, partnering with people who are in the studies to really figure out how to do this well, so that we can look at, what may be the earliest horizon of change, and then know when we might intervene. Now, Suma, you talked about some remarkable studies that are addressing genetic forms of ALS. We have an increasing number of these ASO trials, antisense oligonucleotide. This is a new chemistry. Well, it's not that new, but new to be in the clinic and in neurodegeneration, that can target abnormal genes. And so I think it's safe to say that we are very hopeful that in these forms of genetic ALS that we may be able to prevent the disease before it ever starts. Gaz, you talked about Stathmin-2 as a linchpin sort of molecule that brings together lots and lots of the different pathologies and things that we think are going wrong. And it is a genetic target, so that even in sporadic ALS, where we don't think there's a genetic mutation, a single genetic mutation causing the disease, we might be able to use the same tools to at least treat it very, very early. Preventing it, though, means that we have to predict it, and that's still a challenge for sporadic disease. So
I'll pick up where you left off and say, yes, today we cannot, but I think, projects like Project Mine, like the big genome studies, or the ALS Knowledge Portal, now Answer ALS, like there's so many big groups really doing a lot of sequencing and trying to find these mutations that could be causing disease. Even if we don't find like another big gene like SOD1 or C9orf72, which mutations in these genes would cause ALS, it doesn't mean that there aren't a number of genes or a genetic loci that are mutated that could be linked to sporadic cases as well. We just haven't uncovered those. So I think these large genetic studies are really helpful, and people are still looking at them and mining them and trying to find these needles in a haystack. I also think that there is an environmental component. So it could be a gene X environment effect that's happening. So we know of, toxins that could cause ALS or ALS-like symptoms. We know perhaps, a connection with traumatic brain injury, so there are some things in the environment that could also be causing some of this. We're just starting to understand some of it. So today we cannot, do anything about it, but with the studies such as DIALS that James was just mentioning, digging into the genetics a bit more, figuring out whether there's a genetic plus environment component to some of the sporadic cases, I think we can get there. I think we have better tools today than we did 10 years ago. Bioinformatics is a big deal now. Just really thinking about the genetics in that sense has really led the way. So, we only knew about SOD1 20 years ago, and now we have over 30 genes that are linked to causing ALS. So at some point we will be able to.
Because I would just add to what you just said that, the genetic testing, genetic knowledge is so important. And the first step towards prevention is really awareness of what genes are causing ALS. And that number of the ratio between sporadic versus genetic forms of ALS is continually changing, even over the last 2 decades. And there could be other genes within that bucket, is what we call as sporadic today, and that may be genetic in nature. And genetic testing is expanding, but I feel like there is an opportunity for advocacy as well as for philanthropy to actually expand the work in terms of genetic testing, or even getting the insurance coverage for some of these genetic testing. as well. Just within the past month, I can tell you in my clinic, we have had 2 patients with no family history have a positive genetic mutation, which was earlier called as a variant of unknown significance. But in learning that there are scattered cases who have reported the same mutation, we were able to actually call the lab and upgrade it to a pathogenic association. So the power really lies in numbers, and the more we test, the more we'll find out. But there is some hesitation in the community as well to get the genetic testing done because it's not covered by insurance for the most part, and that puts a bottleneck in terms of learning more as well.
Absolutely.
Okay, thank you everyone for that. Just before Dr. Berry, I ask you to wrap up, I'd just like to encourage everyone to visit our virtual event booths where you can directly interact with biopharma representatives via video chat, as well as learn more about the therapeutic offerings and clinical trials. Just go to the link below this video on our website. On behalf of the McCourt Foundation, thank you everybody for being involved on this session. Thanks to everybody today who have been involved in all 3 sessions. We've just gone past the 6-hour mark. So it's been a fun day. We've learned a lot. It's been fantastic. And I'll hand it over to you, Dr. Berry, just to wrap up. Thank you very much.
Well, knowing that we have 6 hours behind us, I'll be brief. This was really wonderful. We're so grateful to have the chance to sit down. It's fun for us to talk together about these really big issues. I mean, these are incredible questions. I hope we sort of were able to paint the picture that there is an incredible amount of progress in ALS. Really, really hopeful things happening, and happening faster than ever before. And that to make progress, we really need to partner. We need, we need people to be willing to partake in these research projects. Many of the most cutting edge science projects depend on philanthropy to get going. We're all really dedicated to curing ALS. So thank you for participating today. And thank you for everything that the McCourt Foundation has done to bring us together.
Thank you.